Наш мир не стоит на месте. Он стремительно развивается и дополняется новыми данными. За 5 лет человечество произвело информации больше, чем за всю предшествующую историю. Прямо сейчас мы становимся свидетелями развития компьютерных технологий, освоения космоса и инновационных открытий в медицине. Современный образовательный процесс требует от специалистов постоянного совершенствования, в том числе и в вопросах научно-практической квалификации. Возникает острая необходимость в независимой площадке, позволяющей специалистам иметь доступ к передовым достижениям в области терапии. Евразийская ассоциация терапевтов – это уникальный глобальный проект объединения специалистов разных стран и различных областей клиники внутренних болезней, направленный на развитие и совершенствование помощи пациентам терапевтического профиля. Это современная площадка, предоставляющая участникам Евразийского медицинского сообщества доступ к уникальной базе данных, а также возможность обмениваться мнениями и делиться опытом.
Мы объединились здесь, чтобы сложить наши усилия в борьбе за долголетие, процветание народов наших стран.
В Ташкенте открылся 4-й съезд Евразийской ассоциации терапевтов.
В Минске открылся 5-й съезд Евразийской ассоциации терапевтов.
И мы всегда с оптимизмом смотрели в будущее. Нас объединяют общие корни, общая история. И я надеюсь, нас объединяет светлое, большое будущее.
Миссия ассоциации – создание международных медицинских, исследовательских и образовательных проектов между странами Европы, Азии и СНГ. Ассоциация проводит образовательные мероприятия с участием ведущих экспертов. Съезды, конференции, телемосты, школы. Научная программа конференций подготовлена с использованием современных образовательных методик и инновационных форматов. Сегодня ассоциация уже объединяет тысячи практикующих врачей и экспертов из России, Европы, Азии и СНГ. Она помогает совершенствовать медицинские знания и опыт каждый день. Для нас важно сделать процесс медицинского образования непрерывным, современным и максимально доступным. Вступив в ассоциацию, вы становитесь частью глобального сообщества специалистов, работающих под научной и практической составляющей современной терапии.
Добрый день, уважаемые коллеги. Я рад приветствовать всех на втором дне этой конференции.
Good morning, dear colleagues. Great pleasure to welcome you at this conference. It's the 10th anniversary conference of the European Association of Therapists Internal Medicine Congress. Since yesterday, we have been going online because of COVID-19 pandemics. Over 20,000 people yesterday watched our sessions and symposia, and we hope to have an equally interesting program today. Let me remind you briefly what we are going to have right now in the 3 halls, and by the way, we will have 3 cities, 3 halls, Moscow, St. Petersburg and Perm. Right now in Moscow Hall, we'll speak about the results of new and prospective clinical trials, brief presentations, 5, 6, 7 minutes long. We'll familiarize ourselves with the results of studies on Eurasian territories, the studies that will lay foundations for new international projects. In parallel to this, in St. Petersburg Hall, we'll have a session on new horizons of lipidemic therapy, how to combine statins what are the new classes of siRNA, etc. The answers to these questions can be heard at the presentations in St. Petersburg Hall. In Perm Hall, we'll have issues dedicated to polymorbid patients. We say, yes, the patient has cardiovascular pathology, but he has COPD, or heart failure and oncology. What to do with these patients? Later, we will have a speed session. It's the signature format of our association. We will have brief 6-minute presentations there to speak about anticoagulant therapy. Brief presentations followed by discussions where we will discuss all the questions we have been collecting over the last few months. We'll talk about the most topical issues on anticoagulant use. Please note these formats specifically. You will go to the Zoom rooms where you will ask questions, any questions to the speakers. And let's get started now. I'd like to ask all the participating lecturers to respect timing because we need to start our speedy session on time. The first presentation is dedicated to cardiac metabolic failures among young patients with normal body mass and obesity. Polina Yevgenievna, I'd like to invite the speaker. Hello, dear colleagues.
В соответствии с проводимыми исследованиями в нашей стране,
the prevalence of obesity in Russia over the last 10 years grew by 30% among women and 2.5 times among men. It is well known that arterial hypertension plus obesity in the timeline of 10 years from manifestation of clinical symptoms give a 5 times growth of diabetes 2 development probability and cardiovascular diseases. Depending on the body mass index, we have categories including normal weight, excessive body weight, and BMI. The latter is associated with conditions like insulin resistance, dyslipidemia, and hyperglycemia. At the same time, many persons with normal weight can have different disorders of metabolism. Thus, results of one study showed that people with normal weight and with obesity, but with changed metabolic profile, have different dissemination of fat in their tissues, especially visceral fat, abdominal fat, and increased thickness of intima media because of genetic reasons. However, it should be noted that 35% of the patients with obesity were metabolistically speaking healthy, but the data of meta-analysis of 2013 show that these patients had an increased frequency of cardiovascular events and overall mortality 24% higher than the patients with normal weight. Similar results were derived among diabetes patients. The risk of having cardiovascular events in obese patients was 4 times higher than in patients with normal weight. In this way, the purpose of our study was to assess the parameters of carbon and lipid metabolism, adipokines, and hemostasis in young patients with different metabolistic profiles, normal body weight, and obesity. The research population were the patients of the clinical hospital number 11 in Chelyabinsk. Criteria of inclusion: age 18 to 44 and consent to participate in the study. Criteria of inclusion: symptomatic AG, associated clinical conditions, diabetes. Overall, we had 251 participants of the study. Group 1, healthy, metabolically healthy phenotype, BMI less than 25, 62 participants. Second group, metabolically unhealthy phenotype, BMI over below 25, and 57 participants there. Group 3, 16, and group 4, 116 people. Because we had fewer patients in group 3, we comprised this group of BMI, excessive BMI and obesity patients, calling it into one, calling it an obese group. Statistical analysis was conducted by using MedCalc statistics program. Criteria of metabolistic disorder, the following were used: total cholesterol less or equal to 5, triglycerides 1.7, cholesterol, LDLP 1 among men, 1.2 among women, cholesterol, LPLP 3, and NOMA-IR index. Deviation of at least one parameter was considered to be as a metabolistic disorder. The results were as follows. The frequency of inherited arterial hypertensive disorders was high in group 3, but without significant differences. In group 4, the patients were older. The medium systolic and diastolic pressure didn't differ across groups. It should be noted that none of the patients was taking antihypertension drugs or the ones impacting the lipid metabolism regularly. Despite the fact that the deviations of lipid metabolism were represented in the groups, we thought we should present the differences by the disorders. For example, insulin resistance was identified in the group with, more frequently in the group with metabolistically unhealthy profile. The highest concentration of triglycerides and LDLP and LDHP were identified the highest in the group with obesity. The highest concentration of leptin was identified in the group of patients with metabolically unhealthy obesity. The lowest concentration of antipodictin in the obese group, 3, 4. As we looked at hemostasis, we saw the highest discrepancies in fibrinogen in patients' blood serum. The highest differences were identified in groups 3 and 4. Then you can see the results of linear correlation analysis, where we used non-parametric criteria of Spearman. Linear correlations were identified between BMI on one hand and fibrinogen leptin and plasminogen leptin on the other hand. In this way, the most proliferated failures of carbon and lipid metabolism were identified in the young group of patients with metabolically unhealthy obesity. In the group where obesity was healthy, we had a high frequency of combined obesity with arterial hypertension. We identified in the young group of patients positive correlation between BMI and systolic arterial pressure, diastolic pressure, leptin, plasminogen activation inhibitor first type, cholesterol, low density lipoproteins, and a negative correlation between BMI and cholesterol of the high density lipoproteins. Thank you for your attention.
Полина Евгеньевна, огромное спасибо. Огромное спасибо за
Thank you
доклад.
so
Это была
much,
Полина Евгеньевна, город
Polina
Челябинск. И мы
Yevgenievna.
передаем слово для следующего доклада Кириллу Юрьевичу, город
It was
Москва.
Polina Yevgenievna from
Анализ
Chelyabinsk, and now we
факторов
give the
риска,
floor to
влияющих
Kirill
на
Yurievich
отдаленные
from
результаты
Moscow.
через
Analysis
кожно-коронарных
of risk
вмешательств у пациентов с
factors
острым коронарным
influencing
синдромом
the
старше
long-term
80 лет.
results
Я хочу
of the
сказать, что группа
patients
болеет своей
undergone
посвящен отдельный
PCI
симпозиум пациентам поярким. Старше 80
among
лет
the group
относится к
of
категории
patients
хрупких
above
пациентов.
80.
Такие люди
Well,
требуют
yesterday we
особого
discussed
внимания, и
these
на самом
patients.
деле
This group
в
is called
крупных
frail
исследованиях их доля
patients,
не
and they
всегда
require
достаточно
specific
большая.
attention.
Поэтому
In
любые
large
исследования,
studies, the
посвященные
share of these frail
анализу того,
patients
что
is not
происходит с
very high.
пациентом после
So
80
any
наших
research
сердечных, казалось бы,
of
вмешательств,
what's
но
going on
после
with a
80 представляют
patient
особый интерес.
after
Передаю
age
слово
of
Кириллу
80
Юрьевичу.
is of
Кирилл Юрьевич.
special interest, especially after PCI. Kirill Yurievich, the floor is yours. Hello, dear colleagues. Allow me to introduce our work that analyzes the risk factors that impact the long-term PCI results among the patients with acute coronary syndrome above 80 years of age. One of the quickly growing groups of population are the people reaching 80 years old, and according to the existing forecast, by 2050, their number will double worldwide. It should be kept in mind that elderly age is one of the most important risk factors of cardiovascular diseases and therefore death. So, in elderly patients, there are a few specifics of cardiovascular diseases and their cause, which is cardiac pathology often is combined with other severe concomitant pathologies. We should pay specific attention to the patients with concomitant pathologies of renal and liver insufficiency, because these pathologies are transforming the metabolism of drugs and they increase the risk of contrast-induced nephropathy. Also, another typical thing for these patients is to have an atypical clinical picture. According to the existing research, only 40% above 80 MI has a typical clinical manifestation of thoracic pain. Also, they have a higher risk of periprocedural complications during PCI. Another typical thing is a high percentage of patients above 80 have multi-vessel disease. At the same time, I should say that multi-vessel disease of coronary arteries is associated with a worse outcome for the patient. And as of today, there is no single opinion on the strategy of revascularizing these patients with multi-vessel disease. Some authors believe that we should do intervention only in the culprit artery, while intervention in other arteries can lead to unnecessary consequences and complications. Others believe that the complete revascularization will reduce the long-term risk significantly. This is a topical issue because there are very few studies and researches of elderly patients, which is not conforming to the state-of-the-art reality of clinical practice, while to project the data of studies of younger patients on elderly groups is not correct because of the above mentioned facts. The purpose of our study was to define the strategy of treatment of the patients above 80 years old with acute coronary syndrome and multi-vessel disease of coronary arteries. Also to identify general and periprocedural factors of risk that impact the long-term result of PCI in the same group of patients. Our work was based on the retrospective analysis of inpatient and far-term follow-up of the patients with OCS above 80 years old after PCI during the period of 2014 to 2019. The primary endpoint was MACE, such as stroke, second MI, and all-cause mortality. We also studied complications like stent thrombosis, contrast-induced nephropathy, dissection, and coronary artery perforation. We followed up the results during 1 year. On this slide, you can see the statistic analysis method. So the first stage of our research was to define the strategy of treatment of multi-vessel disease patients. Overall, we enrolled 30 patients in the study. Out of them, we have included in one arm, more than 50% of the patients with multivessel disease of coronary lesions. Then they were split into two groups, incomplete revascularization and complete revascularization. Full revascularization included the group of patients who had a one-step PCI, and a group consisting of 71 patients who had two-stage PCI. In terms of their characteristics, the groups of complete and incomplete revascularization were comparable. As for complications like contrast-induced nephropathy and stent thrombosis, both groups didn't identify statistically relevant difference. Same was for MACE. As for long-term follow-up results, in 1 year, the frequency of MACE in the incomplete revascularization group was statistically higher. It was contributed by all-cause mortality and cardiac death. As for a more detailed analysis of the subgroups of one-step and two-step revascularizations, the comparison of these two groups with incomplete revascularization also showed significant differences. On this slide, you can see the Kaplan-Meier curve, which shows the frequency of coronary events incidence of coronary events during 1 year of follow-up. The majority of them happened 3 months after the hospitalization. The second purpose was to define the general and periprocedural risk factors that impact the long-term PCI follow-up results. To do this, we enrolled 630 patients, the mean age 83 years old. A third of the patients had diabetes mellitus, and the rest had renal problems, and 62% had multivessel disease of coronary lesions. The results were as follows. MACE during 1 year, 22.1, all-cause mortality, 17.3%. To define the independent predictors that impact MACE during 1 year, we used Ochs evolution model. This mathematical model, we included in it a number of parameters that you see on this diagram. So initial descriptions of the patients, such as age and sex, concomitant pathologies, morphology of coronary artery failures, and technical modes of PCI. And according to our data, the factors that increased the MACE development risk during 1 year were the following: cardiogenic shock, STEMI, CKD, previous MI. The factors that reduced the MACE risk were full revascularization of coronary arteries, radial approach, and drug-eluted stents. Our conclusions are full revascularization among the patients above 80 after OCS with multivessel disease reduces MACE in long-term follow-up. First of all-cause mortality and cardiac death. Independent factors that increase the frequency of MACE among the patients above 80 with OCS are CKD, cardiogenic shock, STEMI, and previously MI. The reducing factors for MACE are the full revascularization of coronary arteries, DES, and radial approach during PCI. Thank you so much for your attention. If you have any questions, please, you can contact me. The coordinates are given on the slide. Thank you so much for your presentation, a very interesting one. I want to draw your attention to the high level of statistic analysis in this study. We have questions. In the end, we will have a Q&A session. We will discuss them then. And now we have Anastasia Vladimirovna from St. Petersburg. She will be talking about a very interesting study dedicated to the clinical manifestations of the patient. It's a very untypical presentation for therapeutic conference.
Да-да, здравствуйте, уважаемый Александр Григорьевич,
Hello, dear Alexander Grigorievich. Let me present our work, the clinical manifestations of this dysfunction of tempomaxillary lesion and among the patients with failure of cerebrovascular function. The clinical manifestations are usually a manifestation of comorbidity. Comorbidity is, of course, requiring an individual approach for diagnostics and treatment. That's why, for a successful treatment, we need to exercise a tailor-made approach and treat the patient and not the disease. In the development of this combined pathology, an important role is played by the microflora of the oral cavity. The patients have a worse dental status. They have an unsatisfactory level of hygiene and high level of caries. Arterial hypertension usually entails deep metabolism failures. And let's keep in mind that with hypertension, we often have ischemic heart disease, acute MI, and other associated diseases. According to the global epidemiological studies, stroke is an important contributor to death rate in Russia specifically. 80% of those who survived after stroke have disability. The study of cerebral platelets showed a high level of Streptococcus viridis among the patients with unsatisfactory dental status. In recent years, the dysfunction of temporomaxillary joint is considered to be a manifestation of acute failure of cerebrovascular condition. And an important factor here is the patency of carotid artery. Because of compression, the form of carotid artery is changed. It deforms and it becomes twisted with some narrowings. And vascularization is failing, endothelium is damaged, and this brings to the thrombosis factors. The sinus of carotid artery can be deformed. According to the American Association of Neurosurgeons, these factors may lead to the development of high level of arterial hypertension. This may also lead to the failure of neural facial nerves, and that's why we need to assess the temporomaxillary joint of the patient and define his status of cranial vascularization. We need to assess the clinical dental status, define the dysfunctions of the cerebral vascularization, assess the level of hygiene of oral cavity. To evaluate the clinical dental status, we have conducted a survey among 214 respondents aged 45 to 86. 134 patients filled in the Google Forms online. We also conducted this survey in a geriatric unit where 40 patients were surveyed. We had an anonymous survey that included questions on neurological and dental symptoms. To systematize the data, we developed a special statistical system You can see the survey form on this slide. For further study and for the purpose of assessing the dental status, we enrolled the patients with cerebrovascular diseases and failure of cerebrovascular system. The control group was represented by healthy people, 40 in number. We did the primary dental checkup. We assessed the index of hygiene, periodontal index, etc. The results of survey are presented on the slide. The majority of the randomized patients are in the group above 66 years old. The pathology of maxillary joint, temporomaxillary joint, can cause acute failure of cerebral vascularization. These patients show a lower level of hygiene in comparison with control groups. Periodontitis was assessed in the same way, and in the patients with cerebral failure, vascularization failure, we can see a higher level of periodontitis. The patients with cerebrovascular failures have a higher need in treatment. The study showed that the patients with cerebrovascular disease and chronic failure of cerebral vascularization have complaints on headache and crunchy feeling when opening and closing mouth. They are also losing their chewing efficiency, and duration of chewing is shorter. We tested it against the methodology of Professor Trezubov. The results were followed up by the recommendations below to conduct education on the need to do the sanation of oral cavity, to prevent the dysfunction of temporomaxillary joint, to conduct individual hygiene procedures, and to do checkups at the dentist twice a year. To prevent the dysfunction of temporomaxillary joint, we recommend
основной целью которой является нормализация пространственного положения нижней челюсти счет применения
is to normalize the spatial position of maxilla by using pads. The study allows us to do the following conclusions. The patients with chronic failure of cerebral vascularization have a low level of hygiene and index, high need in treatment, intense caries, and they have inflammatory periodontitis and reduced chewing efficiency. The patients are poorly informed about the need to take care of oral cavity hygiene during their disease. We have explained and conveyed the need of regular hygiene and checkups of temporomaxillary joint in case symptoms manifest, in order to prevent the progression of cardiovascular diseases and stroke. Thank you so much for your attention. Thank you. Thanks a lot, Anastasia, for a very interesting message. And let me remind you that all the questions will be asked later at the Q&A session. And while the next speaker is underway, let me give the floor to Dmitry Ivanovich from the city of Gomel. It's a very interesting presentation. We need to know that terminal patients, it's always a collaboration between pathologists and practitioners, clinicians. We are speaking about liver cirrhosis and hepatarial of liver. To understand what was the prevailing pathology in the deceased patients. The floor is yours, Dmitry Ivanovich, please. Hello, dear Alexander Grigorovich and dear colleagues. Allow me to... Can you see my presentation?
Видна, да, презентация? Да, спасибо огромное. Спасибо за предоставленную возможность.
Thank you so much for the opportunity to speak. Great pleasure and honor to take part in your Congress, colleagues.
На самом деле данная работа была выполнена в рамках
This work was conducted during a study headed by Professor Silvonchik. Our main goal was to understand the frequency, types, and outcomes of bacterial infection in the patients with liver cirrhosis. And it was a retrospective analysis where we included 308 patients who died in the hospitals of Gomel and 70 patients who died in outpatient, and we used the data of the coroner service. Etiology of cirrhosis was standard for non-infection outpatient. We had prevalent alcohol-induced cirrhosis, and about 30% had the cirrhosis of liver of unknown etiology. According to the study, we did find different infectious complications in 41% of the patients, and 1/3 had a variety of combined bacterial infection. This is the traditional structure: pneumonia, pyelonephritis, rarely sepsis, and some local infections. At the same time, considering the timeline during which we followed up and enrolled these patients, the criteria of the International Ascites Club were used to define the diagnosis at life. In the majority of patients, apart from their existing diagnosis at life, they had hepatorenal syndrome of first type. Acute tubular necrosis was present in 45% of the cases. It's the failure of canal epithelia that excludes hepatorenal syndrome as a functional complication. In this way, first type hepatorenal syndrome as cause of death. In this group of patients, we defined the following situation: 40% had no morphological changes. This could be explained if they had a true hepatorenal syndrome. A small number of patients had chronic pyelonephritis, and more than half of them had acute tubular necrosis. Later, we analyzed and compared the groups. We compared the groups, first of all, with infectious complications without them, and we defined that the group with infection and acute tubular necrosis infections were more frequent, and this was true for the patients who died in hospital too. Infection increased 5 times the chances of manifestation of acute tubular necrosis. The same was true for outpatient diseased patients. The frequency of infections among the patients without tubular necrosis, we found out that pneumonia was the main trigger to develop brachymatosis, failure of kidneys. What was happening in the global community in this area? In 2015, ICA had guidelines to comprise all types of renal failures in one nosology: acute kidney injury. Why? Because in the past, a traditional scenario for the development of renal dysfunction among the patients with ascites and decompensated CP was hepatorenal syndrome. As you know, hepatorenal syndrome is a functional syndrome, and it should exclude the brachymatosis renal dysfunction. Reclassification of renal dysfunction of kidney cirrhosis was also caused by too strict existing criteria of hepatorenal syndrome, a large number of acute but small increases of CKP with unsatisfactory prognosis. Some other reasons were inadequate evaluation of renal function with CKP because of the reduced muscle mass among the patients at later stages of liver cirrhosis. These patients have sarcopenia, etc., and we can't adequately assess the serum creatinine in them. Besides, it was noted that we need to consider the dynamics of the serum creatinine speed, which is a more important parameter than the level itself. Moreover, there were more and more pieces of information on brachiomatosic failures caused by infectious complications. And the experts, hepatologists, European American hepatologists, were trying to integrate in the global classification of kidney dysfunction. It was suggested by AKIN. It's a global group on kidney failures. In this way, the overall renal failure criteria were increase of CKP for more than 50% if the value was known, and hepatorenal syndrome became a subgroup of subtype of failure. It was usually accompanied with cirrhosis and ascites, absence of response after 2 days of cancellation of diuretics, and compensation of plasma volume, absence of shock, absence of true and false administration of MPVPs. And on the last slide, you can see all phenotypes as it was suggested by ICA. As you can see, acute tubular necrosis is prevalent in this group of patients, but not the true hepatorenal syndrome, which is typical for 20% of cases in combination with liver cirrhosis. You know, acute tubular necrosis and hepatorenal syndrome, they require absolutely different treatment. Vasoconstrictors and acute tubular syndrome patient is a candidate for kidney and liver transplantation. This much from my side. Many thanks, colleagues, for the opportunity to speak. Thank you for your attention and all the best. Dmitry Ivanovich, my cordial thanks for your presentation on this very acute problem indeed. Thank you very much for raising these classifications. We'll have Q&A session in the end. And now we have the next speaker, Alexander Yuryevich from Moscow. He won a grant of the Eurasian Association of Therapists. Let me remind you that we have a competition in the Eurasian Association, and we provide grants for the continued studies for any researcher, doesn't matter if he's young or not. I invite you all to join us. When the competition is announced, please join it. The topic that we have now is the use of AI algorithms to forecast the complications of patients with atrial fibrillation. This is a very important topic indeed. In the next speedy session, we'll be speaking about state-of-the-art technologies that represent a big interest in treating our patients. Great pleasure to give the floor to Alexander Yuryevich. He will report on the result of his study. Hello, esteemed Alexander Grigorievich, dear colleagues. Today, we are going to speak about a trendy topic, the use of AI algorithms, and we'll try to briefly understand on an example what that means. And I'll tell you about my research. So the work is really kindly supported by the grant of Eurasian Association of Therapists. This is my disclaimer, and it was conducted on the basis of the first MGMU platform where I'm working as a consultant. What is an artificial intelligence? It's a capacity to take over do some creative functions with the help of computer when it works on its own. At the modern stage of AI development, statistics and mathematics, this means some complicated models that have to perfectly model some conditions that we observe in reality. And the main goal of using these methods is forecasting and classification. That's it. No creative functions so far. This is complex maths that is aiming at modeling the situation in question. Any model of artificial intelligence takes some signs, such as age, weight of the patient, diameter of his heart chambers, etc. And with the help of these characteristics, it tries to give an answer to the question put by the doctor. Does the patient have heart failure or not? Will the patient have the left apex LAA occlusion or not? Will the patient live long enough or not? What is the difference of this method from traditional scales and scores, CHA2DS2-VASc, etc.? Traditionally, these scores were used for the doctors. They use robust risk assessment system, but they were created for the doctors. And it doesn't mean that they are wrong. No, they are simple and they are working options. When the patient comes, the doctor has to quickly evaluate the risks for the patient to see what are the counterindications for this or that anticoagulant therapy. While AI models are built in a slightly different way. These are very precise probability assessment systems. They work with a lot of input data. They are not intuitively explicit for the doctors because they came from maths and not from cardiology. That is to say, the nature of forecasting methods is slightly different. In case of traditional scales, we need to clearly and quickly give an answer to the question what to do with a patient. In case of intellectual models, we derive a higher probability, but our questions should be more subtle. So here is a small example on LAA thrombosis. Those patients who were sent to cardioinversion. This is the study we're going to talk about today. Patients with different forms of atrial fibrillation. Cardiologists referred them for cardioinversion. The endpoint of this study is the left apex thrombosis or some indirect signs such as floating linear structures, sludge phenomenon that were identified during transesophageal ECG. I did the transesophageal ECG and other doctors as well, and together we were making a decision on the absence of the endpoint, thrombosis and slush phenomenon, to mitigate the mistake of the operator in this sense. We used the Toshiba tool for the design. The patient came and we did transesophageal ECG and we didn't see a thrombosis of LA. Then depending on the result, we talked to the patient, we collected the history of disease, and then we did an expanded ECG. It's an expanded protocol, but it can be reproduced on any machine of expert level. It didn't contain any new parameters such as strain. These are entirely parameters associated with hydrodynamics and also tissue speed. What were the parameters in question? Systolic, diastolic hydrodynamics in pulmonary veins, or better say the accessible pulmonary vein. The parameter of blood flow in LAA and in and also we assess the diameter of pulmonary veins and also the spatial and diametral characteristics of LAA. We tried to cover everything we could regarding left atrium and the respective hydrodynamics as well. Who were our patients? In total, we enrolled 367 patients, mean age 71, 50% men, 50% women. Half of the patients had excessive body weight and they had obesity. On chat to VASC, the index was 4. 90% had arterial hypertension. 1/5 had diabetes 2, diabetes mellitus second type. As for the prevalence of cardiovascular diseases, a quarter of the patients had ischemic heart disease. 16% had MI, and 12% had stroke in the past. About half of the patients had a clearly paroxysmal form of atrial fibrillation. The other patients had, let's say, suspicion for regular form, or they didn't feel any paroxysms clearly. That is to say, these are typical patients, but they are not decompensated, I would say. We have introduced a new parameter. We had to somehow assess the integral tissue speed in left atrium to introduce an integral parameter to assess the wall of left atrium. We used parameters like lateral speed of the shift mitral ring of shift, the shift of the lateral atrium wall, and shift of the lateral atrial wall. All these parameters are can be visualized on ECG, and it can be reproduced on any machine. We calculated these 3 parameters, and we looked at the cubic root, and we then calculated the total figure to understand what the tissue speed was. As for ECG parameters, look at the high level of ejection fraction in left ventricle, some minor angina. And I would say that the tissue parameters are not bad. We can't speak about left atrial severe fibrosis here for sure. What was happening to LAA of the patient? Well, as far as the lung classification is concerned, LAA had flag stalker and chicken leg forms. These are the most prevalent forms of LAA. These broccoli and cacti forms that are associated with high risk were encountered in 25% of the patients. The tissue speed of displacement in LAA was 12 meters per second. It's quite high. And the signs of thrombosis, large indirect signs of thrombosis in apex were observed in 28% of the patients. The global data on thrombosis witness that pure thrombosis, 9% is the maximum, while here we included additional criteria. That's why we have that high rate. As for anticoagulants, almost half of the patients at the moment of inclusion were taking rivaroxaban. 11% didn't take any anticoagulant therapy at all. And an interesting parameter of the median time of taking anticoagulants at the time of enrollment in the study was 2 months, which is very little. 50% of the patients were getting anticoagulants during 2 months and less. 6 months and less was typical for 70% of the patients. That is to say, 25% of the patients were taking anticoagulants for half a year or slightly longer. This is a really insufficient parameter for anticoagulant therapy. What are the factors and independent predictors of the LAA thrombosis? It depends on anticoagulants. It depends on high or low scope of LAA. Fibrillation, atrial fibrillation, ischemic heart disease. A higher diameter of pulmonary veins is associated with thrombosis risk, and low tissue speed as a sign. It's all quite logical. We see the spatial parameter under the curve, 85%. This model, these factors are well describing the risk of LAA, left atrial apex thrombosis. Our group was divided into two subgroups. 70% of the patients were used for training the model, 257 patients. The rest of the patients were used to validate our models. The breakdown was 70 to 30. Our main mission was to forecast the risk of thrombosis of left apex, atrial apex. Before PCI, we considered body mass index, duration of anticoagulant therapy. We collected cardiological history of disease. We looked at the glomerular infiltration speed. ECG parameters with fiber parameters of LAA and hydrodynamics as well. We didn't use any left apex LAA signs because, on the contrary, we try to forecast the risk before PCI. The most simple model one can think of is the adjustment of coefficients for regression, because this is something that we use in our medical studies most frequently. In this table, you can see the horrendous coefficients and the signs we have been talking about. We succeeded to build logistical regression, and later I will tell you how well it coped with forecasting. Another model was classification tree. What is a classification tree? We often use classification trees in medicine. They represent some logical algorithms. For example, we know that patient was taking or wasn't taking some anticoagulants. If he wasn't taking anticoagulants, we look at his ejection fraction. If it was below 40%, the risk of LAA thrombosis is high. If ejection fraction was above 40%, we go to the next sign, which is the diameter of pulmonary vein ostium. If it's higher than a certain threshold, the risk is high. If it's low, then it's low. So on and so forth. These algorithms are called trees in classification. When we develop these trees, we set the depth of these trees. The model shouldn't be so complicated, otherwise it would cope poorly with classification. This model includes both history of disease and a number of ECG parameters. There are several algorithms of classification trees. We use two of them. The third algorithm was a complex neural network. In 1957, American scientist Frank Rosenblatt tried to build the analog of human brain, a supercomputer Mark I. Look at this historical picture to understand how it looked. Indeed, this structure slightly looks at neuron connections in human brain. Thanks God, in 2020, we mustn't do it manually like he did. We can do it on the computer. Generally, the principle is resembling the model I mentioned before. It consists of some input layer, the neurons, and the output layer. That shows us the probability of risk. In our case, it's the probability of LAA thrombosis risk. We used a complicated prototype consisting of 600 neurons. Okay, to what extent did our models cope with forecasting? We remember that the space of the curve during multi-parametric analysis was around 80%. We see a number of models here, two classification trees, regression adjustment, TRF model. This is several trees comprising one. This is a model with boost, XG boost, and neural network. We can see that the total space of the model network is above 80%. Some of them have a high prognostic value, 85, 88% in average. Two models have high level of sensitivity and two of them high level of specificity. They are highlighted in yellow. That is to say, we've achieved what we wanted. We achieved the quality of the multi-parametric regression model. We managed to do our description, and also we even exceeded it with the help of our artificial intelligence model. How should we build our forecast in a right way concerning the thrombosis of LAA? The principle of building all diagnostic pipelines in medicine is a certain question that we have to formulate. Then we have high sensitivity method, then high specificity method, and then we give a response. To diagnose MI, we first use ECG, a highly sensitive method, then we use a highly specific method, troponin test, and then we draw our conclusion on whether or not the patient has MI. In this case, we can use a pipeline from classification tree, then we use neural network, and we can significantly improve our forecast regarding the presence or absence of LAA thrombosis. Well, this is it from my side. Sorry to go a bit beyond my timing. This was the little study I wanted to present to you on the modern methods of analysis. Thank you so much for your attention. Alexander Yuryevich, huge thanks for your presentation. Without any doubt, artificial intelligence deploying technologies and all state-of-the-art technologies are integrated more and more in medicine. And if 5 years ago this kind of a presentation would cause questions, today it's not provoking any questions because definitely the future of the medicine belongs there. I always bring an example, a method of appointing chemotherapy chosen by AI, accuracy of putting a diagnosis of oncological diseases and accuracy of chemotherapy dosage. An artificial intelligence can provide is several times higher than the human capacity. And now we have the final presentation of this session. Anna Yefimovna will speak about diabetic nephropathy with the tools of forecasting cardiovascular risks in the patients with diabetes mellitus type 1. Diabetes mellitus type 1 is always of interest for a practitioner because they may develop multiple complications. These patients are of special focus in the times of COVID-19 pandemics because it underlines a more severe course of COVID-19 infection. And we need to clearly understand that if in the old textbooks it was written diabetic nephropathy causes a big loss of protein, today we may see the albuminuretic or non-albuminuretic type of nephropathy. The floor is yours, Anna Yefimovna from Moscow. Hello, dear colleagues. Let me present our study on the assessment of association of diabetic nephropathy with the forecasting tools for cardiovascular risks among the patients with diabetes type 1 patients. Improvement of insulin therapy methods led to a significant reduction of the frequency of cardiovascular diseases and prolongation of life. In this way, we can compare it among diabetes type 1 patients with diabetes 2 patients. We know that diabetes patients have the highest risk of cardiovascular death. First type in this sense is studied to less extent, although there are proofs to the fact that the relative risk in type 1 of having cardiac death is 10 times higher than in the general population. patients with type 1 have a higher risk of microvascular complications, the most significant one being progressive nephropathy and terminal stage of renal disease. It's important to say that combination of diabetes and nephropathy include the risk of cardiac death 20 times. It has also been identified that albuminuria defines not only renal but also vascular outcomes. Despite having special methods of risk assessment for cardiovascular diseases in place for patients with diabetes type 2, until recent times there was no such method for patients with type 1. The purpose of our study was to evaluate the methods of forecasting cardiovascular risk in the patients with diabetes mellitus type 1. The one-step study included 167 patients with diabetes, 68% women, 31% men, age from 18 to 70 years old, hemoglobin A1C from 18 to 25%. During the study, we evaluated the albuminuria and glomerular infiltration speed parameters. We calculated the cardiovascular risk by using the scores developed for type 1 diabetes patients. During the study, we assessed the age, sex, duration of disease, albuminuria, CKF, regularity of physical exercise, and previous cardiovascular events. The risk of cardiovascular events, diseases was classified as low, medium, and high. The results are shown on the slide. In Steno-Risk-Angine score, Steno-T1 risk angine score that evaluates 5-year risk, the median was 0.93%. In this way, the risk of cardiovascular diseases in the studied group was assessed as low in both scales. Considering the fact that combination of diabetes and nephropathy increases the risk of cardiovascular complications, we have set the expected statistical direct correlations with albuminuria and the reverse correlations with the glomerular infiltration speed with both scales. There's a strong correlation between two scales identified. So the deployment of this method in clinical practice is relevant. However, in Steno-T1 and Swedish T1D risk score, there is a certain discrepancy. In both scores, the calculation of cardiovascular risks have to consider age, sex, duration of disease, level of glycated hemoglobin, and systolic arterial pressure level. The differences are in using the low density lipoproteins. In Swedish T1D, it's total cholesterol and HDLP and microalbuminuria, whereas Swedish T1D score gives a more generic renal failure method. Besides, with the existing limited in time checkup of the patient, the evaluation of physical activity, which we need for Steno-T1 and angine, is more relevant. In this way, the Steno-T1 risk angine and Swedish T1D risk score are, let's say, equally important scores for the stratification of the risk. However, in real clinical practice, it's more reasonable and more accessible to use Swedish T1D risk score. I also want to add that despite the significant increase of life expectancy in the patients with diabetes, very often the higher risk of cardiovascular diseases is underestimated. market. So the further improvement of the methods to evaluate cardiovascular diseases and stratification of these risks among the patients with diabetes type 1 is necessary. Thank you for your attention. Huge thanks for your presentation. Without any doubt, it's a very interesting and important topic. And now we can go to Q&A session. I hope everybody here are still here and you didn't disconnect, because we have the following questions. Question for the first speaker. Presentation of Polina Evgenievna from Chelyabinsk. Here is the question. Can you describe the randomization method of your study? Your audience has a question on these methods of randomization. The method was used, it was random sampling. Thank you for your question. Random sampling was the method. Can you hear me? Yes. Yes, you can respond. So our method was random sampling. Without randomization. All right. Thank you very much. Very brief, yet concise and comprehensive. Question to Kirill Yuryevich. Kirill Yuryevich, what were the criteria of statistic processing and how accurate are your statistic data? Thank you very much for your question. I had a slide on this, but because of the lack of time, I had to miss it. Statistically relevant was a p-value below 0.500, and for statistic processing we used square root and accurate Fisher criteria to identify independent predictors. We used OXIM multi-factor regression analysis. Thank you so much. Dmitry Ivanovich, a question for you. And it sounds as follows. Acute kidney failure and the diagnosis of it is complicated for patients with renal failure. Well, I wouldn't say that it's more difficult to set the diagnosis. I would say that we just expanded the renal failure options diagnosis in liver cirrhosis patients. I presented the data of dissection study. We had biopsies. We had two pathologists who were studying this biomaterial. But diagnostics at live, not post-mortem, we need to use some markers such as gelatinase or some others, but in fact they are not validated for the patients with liver cirrhosis. This might be the difficulty. And it was highlighted that variability of renal failure and the subsequent treatment differ, and we can't narrow it down to the classical option of hepatorenal syndrome equals fatal condition. Okay, let me continue this question. To a practitioner, to a therapist, what should we be guided with, a rifle or a King classification? As for cirrhosis, liver cirrhosis, please keep in mind the guidelines of 2015, because they include several subtypes. And by the way, these guidelines are quite simple. Diagnosis of acute kidney failure, and then classification of subtypes depending on the clinical data. Thank you so much. And the next question for Alexander Yuryevich. The question is, how well can the predictive accuracy of your method be improved? Thank you very much for your question. The accuracy of predictive method definitely depends on the factors that we use as, let's say, input data. If these are highly specific data associated with tissue changes, deformations of LAA, genetics and some other factors, of course, the prognostic value will be really high. But if we are simply trying to forecast thrombosis on the level of dyslipidemia and smoking, and that's it, of course, the quality of prognosis will be quite poor. It all depends on the factors based on which we are trying to forecast thrombosis, or I would say any other diseases and any other endpoints. And a question for me personally, what do you think in what foreseeable future timeline a system like yours or any other AI deploying system will become daily part of our work in Eurasian territory? In Eurasia, I believe 5 years of a timeline, 5 years maximum. You know, the reasons here are not so medical, but rather economic, I would say. Thank you very much. Next question. Anastasia Vladimirovna from St. Petersburg. Anastasia Vladimirovna, can you please clarify, have you assessed the increase of the quality of life of the patients after your study? If yes, then what questionnaires did you use? No, unfortunately, we didn't assess it because we have yet covered only the first step of the study, and its goal was to identify the correlation between the dental condition and the temporomaxillary joint, as well as the somatic pathology. And now, indeed, the patients that were enrolled in the study are being treated, and they are, we try to repair their temporomaxillary joint, and after a while we'll be able to answer this question. So far, it's an open question still. And the last question from me to Anna Yefimovna. Are you with us? Yes. My question is about COVID-19 and diabetes type 1. What do you think, given the pandemics at the moment, and given the fact that diabetes type 1 is a risk factor for a more severe course of disease of COVID-19, are we going to have acute renal failure because of the cytokine storm? Are we going to have a growth of diabetic nephropathy in the coming years? Thank you very much for your question. It's hard to say because we've never encountered these situations before. Quite possibly it will happen, but it's hard to give a definitive answer to this question. Yes, I am asking similar questions yesterday and today to the experts on myocarditis and acute renal failure, and they all say we can't give a clear answer. Maybe yes, maybe no. My personal opinion is most probably yes, because acute renal failures can't be unnoticed for the kidney. They will always leave a trace. Anyway, thank you for your opinion. We are wrapping up with a Q&A session. I want to say thank you to our speakers who, despite the pandemics and the difficulties, keep conducting the clinical studies that should be conducted in any center. This is a scientific work that we do need for further development of practical medicine. We'll have a break now, a 15-minute break, and at 11:30 sharply we'll start a speedy session. It's a unique format of the European Association of Therapists. It envisages 3 parts. Part 1, brief 6-minute presentations where the leading experts of Russia and Eurasia will familiarize the audience with the problems of anticoagulant therapy. Part 2 of this speedy session is a discussion on acute questions that we've been collecting for months, and part 3 is the answers to the questions where every speaker will have a chance to go in Zoom room. You will see in the chats how to do it, and in the Zoom room the speaker will answer your questions in the format of live chat. It's not exactly the same as live conversation. Of course, everything is done online, but I urge you to respond to all the unanswered questions. please do not hesitate to go in the Zoom rooms and ask directly the question. And now we have a break. See you in 14 minutes.
В ваших руках возможность замедлить прогрессирование хронической сердечной недостаточности. Какова цена промедления?
Принимайте по одной таблетке 2 раза в день в одно и то же время.
Спасибо, доктор. Принимать 2 раза в день. Значит, буду принимать в 9 утра и в 6 часов вечера. Кажется, мне надо было принять таблетку в 18:00. Или я ее все-таки принимал в 18:00? Наверное, принимал. Лучше не буду еще раз принимать, на всякий случай.
Треть пациентов сообщили о том, что принимают препарат с режимом дозирования 2 раза в день только 1 раз в день. Таким пациентам может быть сложно выполнять ежедневные активности, связанные с регулярными действиями, такими как соблюдение режима приема препаратов. До 43% пациентов с фибрилляцией предсердий могут иметь различные когнитивные нарушения.
Что сделать, чтобы не забывать принимать лекарства?
А могла ли ситуация сложиться по-другому? Выписываю вам препарат Xarelto. У него простой режим приема – 1 таблетка 1 раз в день. А календарная упаковка поможет не пропустить прием таблетки. Достаточно просто знать, какой сегодня день недели, чтобы проверить, приняли вы препарат сегодня или еще нет. Фибрилляция предсердий может привести к повышенному риску когнитивных нарушений, к развитию деменции, к потере независимости в выполнении повседневной деятельности. Поэтому кратность приема препарата и подсказка в виде календарной упаковки могут играть важную роль в приверженности к лечению у таких пациентов. Xarelto. Всего 1 таблетка в день и календарная упаковка для правильного приема.
Добрый день, уважаемые коллеги. Всем, кто к нам только что присоединился. И мы переходим к следующему шагу.
Hello, dear colleagues, all those who joined us just now, and we have a speedy session now on anticoagulant therapy, complex issues of it, to when, how, to whom administer anticoagulant therapy, acute patients with PCI, thrombopenia patients, etc. We'll try to convey different aspects, and let me briefly remind you, speedy sessions contain 3 steps. First step, brief 6-minute presentations, maximum information, as brief as we can. This step is an introduction to the problem. Step 2, discussion on the most acute questions that we kept receiving in several months. And the discussion will be conducted here in online format. The experts will provide their opinion on every question. And part 3 is an opportunity of direct discussion for every listener. For that, you only need to go on Zoom. The link is in YouTube broadcasting in our live, and you can always turn to tech support for the link. Let's start the speedy session. Let's start from my presentation, which is dedicated to the following. It's the first problem we are facing. It's early diagnostics of atrial fibrillations as a first step to saving lives. We can have the best tools to treat fibrillation, but without diagnosing and without missing this patient, we are likely to have a patient with cerebral failure, vascularization failures. To diagnose timely, question 1 is, who are we looking at? Ask yourselves a question: does your patient comply with these criteria? Because against every syndrome, we have the higher chances for the development of AF. And you can see that a high percentage of people with hypertension, obesity, age have 5-6 times higher chances chances for development of AF, diabetes as well. All these risk factors are increasing the chances for AF to happen. Who should we look among for AF? In order to decide the most optimal method, let's look at the year of life of a patient who is likely to have AF in the future. We know very well what the guidelines say: regular Holter monitor, ECG monitoring. We saw lots of optimistic graphs in the guidelines that contribute to the increased chances of diagnosing AF timely. But if we go step in the shoes of a patient for 1 year, let's try to imagine. Of course, it's gray and black, but let's look at the brightest format: hypertension, ischemic heart disease, chronic kidney disease. When will AF happen? When will the first paroxysm happen? Because we know AF is first asymptomatic and then we will diagnose. How many years before the diagnosis did AF appear? 1 year of a life of patient, 8,700 hours. Let's try to diagnose by using different methods. The only 100% probability of diagnosing or saying it's not there is an implanted device, but we don't have them. What do we do instead? We do Holter monitoring 7 days, twice daily, twice per year. Prognostic value drops to 96%, but we don't have 7-day Holter. We will put the regular one and we will do the monitoring with the prognostic dropping of the value 2%. And so the chance to catch AF early is 2%, but it's not even that. You know, the realistic chance to catch AF at early stage is 0.06%. That is to say, we have the minimal chance to diagnose fibrillation. This is a long-standing problem. What is the solution? The first step is UNSTOPS 2011.
Позволило радикально оптимизировать судьбу этих пациентов, увеличив в том числе дозы и продолжительность антикоагулянтной терапии с 1,5 до 4%.
The dosages and duration of anticoagulant therapy from 1.5 to 4%, and radical changes of the quality of life were possible due to Holter monitors. From elements of Holter monitors, we now go to the portable devices that, by using different optic sensors or photoplethysmography, allow to simply wear these portable devices and detect and early diagnose the AF. The first largest study here was Huawei Heart Study, portable device. Mean age 35 years, and these patients were wearing devices. Out of them, a relevant number was sampled. 0.2% of the people who got notified that they have AF. The mean age 35 years for those who were diagnosed. But you know, the mean age of diagnosing AF is normally 55. But these 35-year-olds, they went to the hospital, and in 80% of cases, the diagnosis was confirmed. The earlier, the better. How many saved lives? This is a second study. This is a study done on Apple Watch. It's dedicated to early diagnosis of atrial fibrillation. It involved more than 4,000 patients, but the number of patients who were diagnosed was 34% out of those who were sampled for further study. It is considered that the accuracy of method Huawei suggests is higher. However, both directions are actively developing. We should clearly keep in mind that the portable devices are the future of early diagnosis of AF, and we have no other way but to use them. And today we're going to speak about how to use this data and confirm the AF diagnosis. Thank you for your attention, and let me give the floor to the next speaker.
О том, что мы можем делать с антикоагулянтной терапией у этих пациентов.
We'll speak about opportunities of anticoagulant therapy for these patients. Next speaker is Gregory Artyunov, protection of elderly patients with AF from stroke as the main purpose of therapy. Thank you very much. I continue the modus of our meeting. Let me draw your attention to the fact that in Russia we have 2,300,000 patients diagnosed with AF. One of the biggest problems is a symptomatic course of disease that can increase the probability of stroke in these patients. While as for the figures, every fifth stroke was preconditioned by AF. The graphs on the left show us a very sad prospect. The number of patients with AF will be increasing. The number of patients with undetected will be increasing. Stroke is not only a problem of state, and also it's a problem of the family. It's a terrible situation. 43% after the stroke will be disabled. Just imagine a family with a patient with AF and this terrible thing happened to them. Look at the purple part of the slide. Speech disorder, 7% increase of the failure of proprioception. All this shows that the problem of prevention of the stroke is of paramount importance. What do we need to know? CHA2DS2-VASc score has been changed. It has been revised. Let's take a deeper look because this is the constituent part of stroke prevention. In the left part, you see the old version of CHA2DS2-VASc. In the old score, the green lines show you where the changes are. First line is CKD, where we have the moderate systolic dysfunction, including asymptomatic. This is something new, and also hypertrophic cardiomyopathy was added. Look at the green line, arterial hypertension, with the target arterial pressure in AF, systolic 120, 129. We'll try to reach it. Keep in mind the hazard of pressure reduction, sharp pressure reduction. Third green line, diabetes, first and second type, and the biggest change in the idea of CHA2DS2-VASc score is in fourth line. MI, myocardial infarction in the past, atherosclerotic clot in aorta. Any other changes? Yes, algorithm of medical care. We are looking at what remained unchanged. The dark red line on top tells us that if the patient has a mechanic valve, if he has moderate or severe stenosis of mitral valve, the green arrow, the yellow arrow shows that nothing will change. He will be getting his therapy with warfarin or vitamin K antagonists. Look at the second red line with step 1. An unexpected step is to define the low-risk patient. Who is the low-risk patient? It's a patient who has 0 in the CHA2DS2-VASc score, 0 among men and 1 among women. Look at the arrow. You leave them without treatment. You follow them up, but without administering antithrombotic drugs. We have highlighted 2 populations of patients. The others should get therapy. The white arrow shows step 2. You have calculated the risk. You need to administer oral anticoagulants to the patients. Look below, class 1. If your patient, a man, has 2 or above, or a woman has 3 or above, according to the score, you have to give them oral anticoagulants. If if a man has score 1 or a woman has 2, consider to a recommendation clause and convince the patient to take the therapy. This is the most efficient way to prevent the primary stroke in the patients. Look at the black part of this slide. 9 out of 10 patients with AF at the moment of the first stroke didn't have enough anticoagulation. The biggest thing we can do is to administer wisely for efficient anticoagulant therapy. Please note that this is the prevention of primary stroke. We'll later speak about secondary stroke, about the primary one. With the right application of the algorithm that we've just analyzed, and CHA2DS2-VASc score, this is an option. Thank you very much. The floor is to the next speaker. Dear colleagues, we move on. The next speaker, Professor Yevgeny Nifontov, St. Petersburg. Can the risk of coronary events be reduced in AF patients? We know coronary death, cardiac death is the first reason for the patients with AF. The floor is yours, Yevgeny Mikhailovich. Dear colleagues, good afternoon. Yevgeny Mikhailovich, I would like to remind you that we often face a situation when over 40% of the patients with AF eventually die from different coronary events. So by using anticoagulants, we need to not only reduce the risk of cerebral vascularization failure, but also we need to influence the coronary risks of the patients. This is a new chance, a new threshold of using the anticoagulants. Yesterday we had a slide on how the anticoagulants are treating ischemic heart disease. Today they are expanding their borders beyond AF and POAC. Today, they reduce the probability of coronary events. It's a very important step. We're talking about diagnosis, prevention of primary stroke, reduction of risk of coronary events in these patients, and then we're going to speak about the patients who require PCI. Then we'll talk about worsening renal function, because when we talk a lot about the cardiovascular challenges, we have no right to forget that these patients have deterioration of kidney function, and in fact atrial fibrillation is a condition which is quite severe. It's the risk of coronary events, chronic kidney disease. Of course, it's the target lesion failure, dimension, etc. I want to give the floor to Yevgeny Mikhailovich for a presentation on coronary events. Yevgeny Mikhailovich, the floor is yours. Dear colleagues, I do hope you can see me, you can hear me. We're going to speak today about something that will be applicable to all AF patients sooner or later. If we look at the mortality causes for AF patients, we'll see that it's not the ischemic stroke the main reason for death, but some other events that develop in the patient, even if he doesn't have AF. It's a chronic heart failure, arrhythmia, sudden cardiac death. There are many conditions predetermined by heart. So we should always keep in mind, do we have this extra option when we, as we protect the patient from ischemic stroke, can at the same time prevent this particular scenario, because this becomes a reason for death more frequently than the ischemic stroke. If we look at the toolbox, we may say that today there's a good portfolio for rivaroxaban, and all-cause mortality up to 42%. Colleagues, this is a very important risk reduction. Unfortunately, other drugs that are used for the prevention of stroke, these studies haven't been conducted and they haven't been finalized. Chronic ischemic heart disease. Again, here we can give a chance for a patient to live longer. All-cause mortality reduction by 18%. Unfortunately, no studies were conducted in this respect either. Peripheral artery disease. This is already also an index of higher coronary risk, thrombotic event reduction by 15%. Unfortunately, we realized that not all of the direct DOACs have these indications. We can't ignore the fact that according to the meta-analysis of randomized clinical trials, rivaroxaban has proven risk reduction of acute coronary syndrome, MI, in average by 20%. Colleagues, unfortunately, we have to admit that these data were derived not only for rivaroxaban. Other drugs that are used for stroke prevention cannot demonstrate an at least close impact on the results, on the prevention of coronary events. Another problem is we always keep thinking that maybe the good old warfarin is not so bad at all for coronary cardiac events. But unfortunately, it entails a lot of problems, first of all, associated with calcification of lesions, almost all lesions. During lengthy administration, the calcification of coronary arteries is proportional to the time during which the patient was taking warfarin. This is a very serious problem associated with microcirculation. Plus, we have the recent data showing that compared to warfarin, rivaroxaban contributes to the reduction of atherosclerotic clots. They shrink in volume, and also the main clinical and lab parameters of these clots are shrinking as well. The average size of the clot is going down as compared with warfarin, and this is true for calcified clots as well. There has been recently introduced the meta-analysis of randomized clinical trials, which analyzes the outcomes of the treatment of oral anticoagulants among 196,000 patients. This is a huge study, and the best treatment option for the patient was evaluated. The endpoint was prevention of MI. 61% was for rivaroxaban, 14% for abexaban, and 0.1% for dabigatran, and vitamin K antagonists, 2.4%. I think the figures witness to themselves. In this way, we may say that today an AF patient who gets oral anticoagulants will most frequently die from a complicated heart disease. And when we are dealing with AF, we need to assess the risk of developing severe complications of cardiovascular diseases of the whole range, and we need to therefore reduce the risk of cardiac events. And the criteria of choice may be a DOAC for AF patients. Dear colleagues, I do hope that the hearts of our patients won't be broken. This flower is called Lucentra, or a broken heart, but it's not true for our patients. We will do everything to not let it happen. Thank you.
И мы движемся дальше по программе. И следующий доклад Алексея
Evgeny
Николаевича
Mikhailovich, thank you so much. We move on, and the next presentation is Alexei Nikolaevich will be speaking about AF patients before and after PCI, approach to the prevention of thrombosis. This is a big topic. We got a lot of questions on PCI yesterday and today. When to choose anticoagulants, when to administer, how to administer. I do hope to hear either questions in this presentation or the audience will have a chance to contact Alexei Nikolaevich during Q&A and ask him the questions. And the floor is yours, Alexei Nikolaevich. Hello, dear colleagues. Thank you very much. Indeed, AF patients who are subject to PCIs is a special group that always has complications in getting antithrombotic antiplatelet therapy. We have to administer anticoagulants to them, and it entails a lot of difficulties. Speaking about the importance of this problem, I have to say that in Russia today we have a national project ongoing on increasing life expectancy, reduction of mortality from cardiovascular diseases, and part of the project is the further increase of accessibility of PCIs. The number of procedures, PCI procedures in Russia is growing. They are planning to optimize the angiographic machines, to install new angiographers in the institutions that don't have it, and to provide PCI availability in the centers in patients with acute coronary syndrome. Let me remind you, it's a life-saving procedure. The patients that had MI and have atrial fibrillation is a special group of patients of high risk because concomitant AF is significantly worsening the outcome of MI patients. The risk of lethal outcome in the hospital is 4 times higher, and the risk of MACE in 1 year after MI is also high if the patient has AF. It's important to keep in mind that when we use DAT therapy in combination with perioral, with POACs in a patient with OCS and AF, this patient is subject to 3 risks. Apart from embolism risk of hemorrhagic complications that get stronger when we add additional disaggregants. The patient has a risk of MI development, and very often after PCI, he also has a stent thrombosis risk. Many risk factors that are enumerated here are at the same time risk factors of ischemic events, embolism, and they increase the hemorrhage risk. When we choose the drugs to treat the patient who should get disaggregant anticoagulant therapy, we should keep in mind that the new perioral anticoagulants supersede vitamin K antagonists in efficiency by preventing the embolism and embolic stroke, and in terms of safety, which leads to the reduction of the frequency of large-scale hemorrhages if we use this class of drugs and not vitamin K antagonists. Evgeny Mikhailovich was talking about analysis that enrolled almost 200,000 participants. In this meta-analysis, the frequency of MI is lower on the patients who used anticoagulants than in the placebo group. Rivaroxaban Xarelto 2.5 mg was something my previous speaker mentioned. But look, Rivaroxaban 20-25 mg that is used for prevention of embolic stroke in AF patients. It also has significant advantages. If we evaluated the effect in 2 folds, risk reduction of MI and reduction of all-cause mortality, and the contribution of MIs in this parameter. Rivaroxaban is researched in the patients after PCI in Pioneer AF PCI study, where the therapy was compared with vitamin K antagonist therapy in combination with clopidogrel, acetylsalicylic acid, double therapy in combination with clopidogrel and rivaroxaban 2.5 mg for 6 6 months, triple therapy in combination with acetylsalicylic acid, with further switch to the double therapy, same as in second group. The result of this study shows that the risk of hemorrhagic complications is much lower in these patients than the ones who got Xarelto, as compared with the patients who got warfarin, vitamin K antagonists. If we look at the ischemic events that were the secondary point in this study, we will see that the frequency who got standard therapy at that moment, and this was the first study at that moment on NOACs, stenting among the patients with AF. But here we will see that we don't have it. In the future, a similar study will be conducted with using other drugs as well. Here we can see that the study on the efficacy MACE cardiac death, unfortunately, these parameters were secondary points in these studies, but today we have tested the hypothesis. We know that these drugs are safer, but when we talk about advantages of different perioral anticoagulants, we cannot always be sure that their findings can be extrapolated on the PCI patients. At the same time, it relates to anti-ischemic effects of rivaroxaban, but we know that with NOACs, these drugs unfortunately are faster introduced in the guidelines than they accumulate the evidence base. I have to note that patients who take disaggregant therapy, who have been stented, the one-time admission, which is associated with higher compliance and lower risk of therapy, is, of course, we should keep in mind that they have one extra risk, MI risk and cardiac death risk. So compliance is of greater importance for them. In the new guidelines that we talked about, rivaroxaban has the highest class of recommendation. All the patients are recommended to use NOACs, and in combination to a class, rivaroxaban is recommended for the patients with AF and MI. Thank you so much for your attention. Dear colleagues, thank you so much for this presentation. And we would like to move on. Well, having gone through coronary risks, PCI, the next topic is renal function. Renal function is compromised for any living creature with age. It goes down for any patient with hypertension, diabetes, any patient who has metabolism syndrome. We can continue this list on and on, but let's talk about whether or not we can reduce the risk of CKD progression for a patient who takes anticoagulant therapy. Great pleasure to give the floor to Professor Natalia Andreevna, who is a moderator in Perm Halls. The floor is yours, Natalia. Thank you so much, Alexander. Dear colleagues, my mission is to respond to the question, can we reduce the risk of compromised kidney function in patients with AF? CKD is frequently encountered in AF patients, 30-35% according to different registries. Who is the and that's the contributor to the terminal renal disease. What are the factors? It's diabetes, of course, hand in hand with arterial hypertension. When we have chronic kidney disease and AF, the recent Garfield data say that the chronic kidney disease, depending on the stage, endangers the patient with higher risk of hemorrhage, double the times. Stroke and embolism, they increase 1.5 times, and it endangers the patient with acute coronary syndrome and chronic renal insufficiency. But most importantly, dear colleagues, this doesn't depend on the severity of kidney disease. Patients with AF have a 1.5 increase of the sudden cardiac death risk. The non-cardiac death risk is increased 1.5 times, and all-cause mortality 1.5 times higher, irrespective of the severity of chronic CKD. So we need to downsize the risk of systemic embolism, stroke, and more importantly, slow down CKD development in AF patients. Over 3,000 people were involved in this study, which says that unfortunately AF increases the risk of terminal CKD 3 times. What do we need to give to AF patient and CKD to ensure prevention of thromboembolism and prevent death? The recent meta-analysis of the 4 randomized trials says that these patients should be given NOACs that compared with warfarin are better in terms of reduced large hemorrhages 20%, all-cause mortality, etc., by 9%, etc. We have new definitions when we talk about the patients with the deteriorating renal function. The renal function worsening, as a term, nobody argues about it, but worsening of infiltration function. It's the clearance creatinine reduction at any moment of study for more than 20% in comparison with screening value or initial value. And when we talk about the compromised renal function patients, today we have the only sub-analysis of a randomized clinical study. For these patients with AF, the worsening of renal function convincingly shows the efficacy and safety of rivaroxaban in comparison with warfarin. This is a sub-analysis of ROCKET-AF study where the infiltration function of kidneys in the patients was more than 20%, and this analysis says that if the patient with worsened infiltration of renal function is given rivaroxaban, we will decrease even more the risk of stroke without increasing the hemorrhage, the risk of bleeding. And if for some reason the patient with creatinine clearance less than 50, the patient will get a wrong higher dosage of rivaroxaban, 20 mg. His creatinine clearance went down. We didn't evaluate it. He didn't come to the checkup timely. Even in this case, we will have even a bigger reduction of stroke risk and systemic embolism without increasing risk of bleeding. We'll have a huge span of safety for rivaroxaban for these patients with worsened infiltration of renal function. But we want to have more, not only reduction of stroke probability, bleeding with rivaroxaban. We want to slow down the worsening of kidney function, and it's quite realistic. Look at the AF patient with diabetes. If they take rivaroxaban, we slow down by 30% the reduction of glomerular infiltration speed, which goes down by 30%, and we slow down the serum creatinine, and also we prevent to 25% of probability acute renal failure. A patient with AF and diabetes, if it takes rivaroxaban, it slows down by 68% the development of terminal renal disease. And in this way, by answering to the question, can we reduce the risk of worsened renal function in the patient with AF? We answer yes, of course. Rivaroxaban helps us to do it, and it ensures not only in the reduction of stroke, risk, and it slows down the bleeding risk, but also it has a nephroprotective effect. We can speak about nephroprotective effect of NOAC, such as rivaroxaban. Thank you for your attention, colleagues. Well, having talked about what to do, what to administer, and what should be the preventive measures for the patients with AF, the next presentations will be dedicated to the complications that may develop, and they might become very, let's say, bitter obstacle, because the next presentation by Professor Tarklovskaya will be dedicated to the persistent bleedings. Tatiana Ivosevna, the floor is yours. Hello, dear colleagues. If we look at the frequency of bleedings in AF patients who get oral anticoagulants, we'll see that they don't have major bleedings, up to 7%, while what dominates are the small bleedings that are 60% statistically. And among small bleedings, we may say that we have prevalent nasal bleedings, possibly the gum bleedings, some subcutaneous hematomas as well. And of course, the patient is scared from the bleeding, and he may stop taking anticoagulants, and unfortunately, this is not the same for his outcome, because we see the increasing rate of stroke frequencies, of systemic embolism, even when the patient is temporarily interrupting his treatment, not saying of the cancellation of anticoagulants at all. And the biggest question we need to realize and to convey this to our patients is a small bleeding a predictor for major bleeding that will endanger the life of the patient? The answer is negative. According to the test data of this register, according to the analysis of this register, we see that the patients with persistent bleedings didn't have the definitively increased risk of major bleedings. This means that persistent bleedings shouldn't be a reason for a cancellation or a change in anticoagulant therapy. Then there comes another question. Okay, this bleeding is persistent. What should the doctor do with this patient who keeps having these bleedings? The answer here is quite simple. We need to look for all modifiable risk factors for bleeding and try to influence them. We need to normalize arterial pressure. Look at the list of drugs the patient is taking and remove from there the drugs that may boost bleeding, NPVPs, disaggregants, etc. The failure to comply to the admission regime of anticoagulants is another important thing. Specifics of the patient, some individual features, labile MNO can be one of the reasons, warfarin and the wrong dosage. There is no algorithm, and the existing algorithm of the Eurasian Association of Therapists is aiming at reducing the risk factor for bleeding. There are 4 points here: correction of elevated blood pressure, minimization of drug-to-drug interaction, assessment of patients' alcohol consumption and its reduction in a patient with prone to bleeding, and check patients' compliance to drug taking and frequency. That is to say, we first of all need to understand why is it that the patient keeps manifesting bleedings and whether we can eliminate the risk factors contributing to that. In this way, at the moment, colleagues, we realize that minor bleedings are unpleasant in the life of a patient, but it's rather safe. It doesn't require the cancellation of NOACs, and a replacement of one drug with another is not indicated because the class effect of anticoagulants is the effect of the class. Most probably, this patient has a risk factor that leads to these persistent bleedings, and very often they are caused by modified or potentially modified risk factors of hemorrhages, and we can correct them and remove the persistent bleedings that prevent our patients from having a high quality of life. Thank you so much for your attention. Ekaterina Iosifovna, thank you so much for your attention. We move on. Unfortunately, Mikhail Mikhailovich, we have to skip his presentation for respected reasons, but this topic will be raised and discussed. Hematuria will be discussed later. And now let's give the floor to Yana Arturovna. She will speak about the slowdown of brain aging. We know that dementia caused by numb or small strokes is an important mechanism that makes the human being fall out of life. Yana Arturovna, the floor is yours. Dear colleagues, Alexander Grigorovich has read almost half of my presentation. When he was announcing it, I want to say that in AF, and there are lots of reasons for that, we clearly see the worsening of cognitive functions, even if there are no major strokes in a patient. And for that, there are several reasons, purely hypothetical reasons, or the ones that we can only assume. Firstly, cognitive dementia and unstable angina are age-caused diseases. They can be hereditary or not, but both diseases are called processes of systemic aging, and it's hard to argue with that. There are several suppositions on modified factors in what concerns the development of cognitive defects in AF patients, and of course its perfusion of cortex, which develops with the non-optimal heart rhythm. And the second circumstance that is being discussed a lot is the emergence of subclinical microembolisms, the so-called non-infarctions of cerebral infarctions. They leave the vascular loci that we can see on MRI. There are lots of studies showing that the number of these loci correlate with the risk of developing dementia. However, dear colleagues, at the moment, we can't definitely speak about the reasons for the failure of cognitive function in AF. And it's hard to suggest a clear and reliable way of struggling with that, both in what concerns the rhythm control, heart rate control. There are clear reasons, but there are no reliable proofs. And of course, these in the coming years, we may get the answers, but so far we don't have them, and we can only discuss this problem and try to help our AF patients of elderly age who, as a rule, have more or less a cognitive deficit. They often forget to take their drugs. That's why once daily regime use of calendar packs can be of use for them. Calendar pack will, of course, not be a clear reminder of taking anticoagulant, but it gives a chance not to have the same drug twice. And this is probably the most important component, because if the dosage is exceeded, the risk of bleeding is increased significantly. So, colleagues, this is an extremely important topic, and maybe we are going to face significant discoveries on this way. Thank you for your attention. Dear colleagues, Yana Arturovna, thank you so much. And we are moving on. Why is the program built in this particular way? Because what we did is we diagnosed AF, we protected the patient from stroke, we responded to the issues of coronary event risk, we protected the patient from the compromised renal function, we discussed what to do in PCI patients, persistent bleedings, possible progression of dementia have been covered, and now we have the second situation of having the second stroke, and the conclusive part of presentation of part 1 is a presentation of Stanislav Sergeyevich on the secondary prevention of the stroke in AF patients. Stanislav Sergeyevich, the floor is yours. Dear colleagues, good afternoon. As you know, ischemic stroke is one of the most topical diseases of neural system with high frequency of lethal outcomes and disability. It's important to see if there are possibilities to administer or renew anticoagulant therapy in a patient who already had stroke in the history of his disease. As you know, cerebral tissue is prone to transformation, which is proportional to the ischemic locus in the brain. If the loci is 50 cubic centimeters, the probability of it being transformed into hemorrhagia is increased 5 times. If this locus is tumorous and it is involved in pathologic ischemic process, this probability is 20 times higher. As we know from Dinner's rule, was left out from our clinical practice. So what do we have in terms of renewal of anticoagulants? We have the guidelines of Upgrade 2019 of American Cardiac Society and Ischemic Stroke American Society. It describes that for the majority of the patients with stroke, with AF, it is reasonable to administer perioral anticoagulants for 4 to 14 days. What does it mean in real clinical practice? It means the following. If the patient has ischemic stroke that happened as he was taking anticoagulants, the first thing we need to do is to cancel this therapy and make a pause. The existing guidelines of 2020 say of the European Society of Cardiologists, the conference took place this year online, and it was broadcasted from Amsterdam. So the guidelines say that AF patients with acute ischemic stroke, early anticoagulant therapy in the coming 48 hours, now with using non-fractioned heparin or low molecular heparin and antagonist K, vitamin K, is not recommended. But the timeline of readmission is not mentioned either. Guidelines tell us that from the viewpoint of a cardiologist, anticoagulants should be reappointed after consulting with a nephrologist. But in the majority of cases, this should be done 2 weeks within 2 weeks after the ischemic stroke. Another complicated question is, I'm sorry, colleagues. The cornerstone question is when should we administer or renew the admission of anticoagulants after a hemorrhagic event? The guidelines describe the time window equal to 4 weeks from the debut of the acute hemorrhagic stroke. At page 65 of the guidelines, dated to 2020, there's an algorithm of administering anticoagulants after hemorrhagic stroke, and the essence is administering anticoagulants after acute cerebral event is possible either within 2 to 4 weeks, but the guidelines though don't say why exactly 2 weeks, or an option is to do occlusion of late LAA, or another option is absence of therapy to prevent ischemic stroke for a patient who had hemorrhagic stroke in his history. At the presentation of Professor Diner at this conference, it was dedicated to the cancellation of therapy after hemorrhagic stroke. In the past, we see that those cases when the source of bleeding and the risk factors were eliminated, perioral anticoagulants can be administered in the interval 2 to 4 weeks. The current guidelines tell us that all the perioral anticoagulants, they are enlisted here. Our patients are all indicated to take DOACs with maximum class of evidence and recommendation. But if we look at the indirect evidence of DOACs, in the overwhelming majority of cases in ROCAT-F, more than 50% of the patients are the patients who in the past had a transitory ischemic attack or ischemic stroke. And in ROCIC-AF, which studied patients with AF, the therapy of rivaroxaban is associated with low risk of death. This is about randomized studies. In real clinical practice, in terms of assessing efficacy and safety of Russian population and our international colleagues, it shows a convincing safety and efficacy profile if rivaroxaban is administered to the patients. As far as we know, this drug can be given free of charge to our AF patients who had acute cerebral vascularization failure. Thank you for your attention, dear colleagues. Dear colleagues, I'd like all the experts who were present here, who delivered presentations, turn on your cameras so that we could cast you on the screen, because we're starting a discussion based on the number of questions that have been asked. Let's try to discuss them. Dear colleagues, let's set up our cameras. Okay, so I'd like to raise the questions. In total, we have around 9 questions, and I'd like to start the discussion from the question on the reasons and diagnosis. This question has been asked several times. I know it was based on a series of publications that were issued before the pandemics, which says about a higher frequency of small heart anomalies in the patients who have atrial fibrillation, open oval window prolapses of mitral valve, or additional chorda. From your perspective, do you think these patients need a special requirement, a special attitude if they have atrial fibrillation? Professor Arutyunov, yes, thank you very much for the question. I think there have been conducted any specific studies on this, but if it's an oval open foramen and there is blood ejection, it's another problem of infection. Let's not forget it, because the possibility of infection and adverse events is there. As for anticoagulant therapy, there shouldn't be any additional ones. From my perspective, we have no reasons for that. The absence of studies actually doesn't give us a right to exercise a specific approach to the treatment of these patients. Yes, we don't have reasons. Theoretically, we can assume that depending on the foramen size, depending on the destructive flow of blood, we may expect the onset of thrombosis, but we don't have this data, and to alter the dosage of the drug, we have no reason to do that today. So follow up the patient, continue the IVUS, control if he manifests some other reactions, control his teeth, sedimentation of infection, infectious endocarditis prevention is much more important here than change the dosage of oral anticoagulants. Who else wants to speak up?
то мы переходим
If
к
not,
следующему вопросу.
we go to the
Первый
next
доклад был
question.
посвящен,
The first
наверное, новому
presentation
шагу,
was
новой вехе в
dedicated to the new
диагностике фибрилляции
step,
предсердий.
a new
Это
threshold
диагностика
in
с
the
помощью носимого
diagnostics
устройства.
of
Все мы
AF
знаем о сложностях,
by
которые
using a
существуют
portable
сейчас с
device.
использованием этих
We all
средств в
know
России,
how
но в
difficult it
ближайшие
is to
месяцы,
use these
годы эта
portable
проблема может быть
devices
решена,
in
она
Russia,
решается и
but in
технически
the
разными
years
путями.
and
Представим,
months
что
to
к нам на
come,
прием
this
приходит
problem
пациент,
might be
у которого
solved.
диагноз поставлен
Let's
часами
imagine
или
that we
любым
are
другим носимым
admitting a
устройством.
patient
Какая тактика,
who
которая
was
зафиксирована, там же не всегда фиксируется
diagnosed with a
пароксизм, там
portable device.
фиксируется
The
ненормальный ритм по
paroxysms
именно
are not
динамике
always
ритма.
fixed.
Это
The
не
abnormal
классическое ЭКГ,
rhythm
не
is
всегда это
always
классическое
fixed. It's
ЭКГ.
not a classical
Представим, что у нас на
ECG, and not
приеме такой
always it
пациент.
is.
Какая
Let's
наша
imagine that
тактика
we
действий в
have
этой
this
ситуации?
patient walking
Что
in.
должен
What is
делать
our
практикующий
strategy of
врач? И здесь я
actions?
попрошу всех
What should
экспертов
a
высказать свою
therapist do
позицию.
here?
Что должен
And
делать
dear experts,
практикующий врач
please
в такой
express your
ситуации?
opinions. Speak up, everybody.
С
What
моей
should we
точки
do in this
зрения, поскольку вы
situation?
обращались ко
From
мне, я считаю, что
Since
он
you
должен
were
сформировать
asking
особую
me,
группу
from my
наблюдения.
perspective, I
Такой
think
человек
it's a
уже
special
находится в
follow-up
группе
group.
особого
This
риска
person is
или
also
особо высокой
already in the
вероятности
group of high
выявления
risk
каких-то
or
нарушений,
a
в том числе, между
specifically
прочим,
high
фатальных
rate
нарушений
of
ритма. Это могли
probability
быть
of
какие-то
having
другие пробежки
rhythm
этого
failure.
человека.
It could
Поэтому,
be
если
some
он формирует такую группу из
fatal
своих
rhythm
пациентов,
failures.
группу
So if
усиленного наблюдения, усиленного
this
контроля,
group
то
of
здесь-то
special
как раз и
control
зазвучат
of the
все, что
patients
касается
is
долго
made, it will
носимых
be
опытов,
right.
все, что касается
And
ультразвукового
all the
исследования
problems
и очень
associated
частых
with
наблюдений за этим пациентом.
ultrasonic
До тех пор,
studies
пока не
and
будет на
halters
обычном
that
КГ
are
выявлено,
worn
наверное,
for
ставить
several
диагноз будет
days
очень сложно.
until
Но тем не менее,
examining
такое
this
длительное
patient on
наблюдение, то
ECG.
есть не
It's hard
надо
to
на
put
всех
a definitive
распыляться. Надо будет
diagnosis.
сконцентрировать
But,
свое
you know, we
внимание на
need to
этом человеке.
focus
Это
our
особая
attention
группа.
on
У нас
this
раньше никогда не было
group
таких
of
пациентов и таких
patients.
групп
We never
пациентов.
had
Но
these
их
groups of
создание– это
patients
реальное
before, but
веяние, это
creating
реальное
them
современное
is
состояние.
really
Я думаю,
trendy
что
in
будет
modern
достигнут какой-то
conditions. I
консенсус
think
экспертов,
we
как
may
вести себя дальше.
achieve a
Пока алгоритмов
consensus
нет, и это
how
повод для
to
очень
behave.
серьезного
So far,
обсуждения.
there are no
Это, наверное,
algorithms,
повод,
and it's
который
a reason
объединит
for a big
экспертов ЯТО
discussion.
и заставит
And it's a
обсудить этот
reason
вопрос.
maybe
Но
to
в любом
bring
случае,
together the
пункт
YATO
первый– это
experts
особая
and
группа
give
наблюдения.
answers to this
Пункт второй–
question.
это очень
Well,
частое,
number one, it's a special
повторяющееся
group that
исследование
should be
для
followed
выявления
up. Point number
нарушений. И это
two, it
ультразвуковое
requires a
исследование, которое
study,
позволит оценить
an
размеры
ultrasonic study
предсердий,
to
вероятность того, что там
evaluate the
происходит,
size
исхода
of
конфигурации
atria to
рожка.
see what's
Кстати, не
happening
надо
to
забывать
the
об этом.
apex,
Если мы
shape of
выявим
the apex.
конфигурацию
Let's
рожка,
keep in
неважно,
mind that
какой она там будет,
haven't
если оно этого человека,
detected
и
the
крыло
shape
цыпленка
of
или
the
капуста,
apex,
капуста 8 раз
whether it's
увеличивает
chicken
вероятность
wing or
тромбообразования.
broccoli.
Поэтому, видите,
Broccoli
целые
8
какие-то
times
алгоритмы, шаги в
increases the
алгоритме уже наличествуют.
platelet
Во
formation
всяком случае,
probability.
не
So
махнем
some
рукой,
steps can be
формируем группу.
done.
Это
We
Григорий
моя
Павлович,
should
позиция.
Григорий
decide
Павлович,
in a
в вашем ответе я
consensus.
услышал много скепсиса и настороженного отношения к возможности
Gregory
этого диагноза с
Pavlovich,
помощью
I
носимого устройства.
heard you were
Да,
quite
сформируем группу, да, будем
skeptical
выполнять какое-то
about
продолжительное
portable
контурское
devices.
мониторирование.
Yes,
Считаете ли вы, что
we can
действовать надо
make an
немедленно, как
expert
только
group
пришел
and
такой
do a
пациент? Ведь
long-term
прогностическая
Holter
точность
monitor.
отдельных устройств
But do you
выше
think we
90%.
need to act immediately because the
Или просто
prognostic
формируем
value of
групповые
the
формы?
portable devices is above 90%, or
Нет,
we
подождите.
simply make a
Вопрос
group and
звучал
that's
не
it?
так. Если вы
No,
формируете
that wasn't the
группу,
question.
что
If
у
you
вас в
are
основе?
making up the
Если вы
group,
зафиксировали
what
фибрилляцию
is it going
предсердий,
to do?
незачем ломать
If
голову.
you have
Какая
diagnosed
разница, какое
AF,
устройство
no
зафиксировало
need to do it
фибрилляцию
again.
предсердий? А
What does
если
it
у
matter
вас
which
какое-то
particular device
непонятное
has done
нарушение
it?
ритма, вы не
Well, if you
понимаете, что
have some
происходит с вашим
unclear rhythm
пациентом,
failure
потому что
and you don't
далеко
know
не
what's
каждое
happening to
устройство
your
может
patient,
зафиксировать фибрилляцию
because
предсердий.
not
Оно
every
может
device can
зафиксировать какой-то интервал
detect
нарушения
AF.
ритма,
It can
временной интервал.
detect
Вот
some
тогда надо
temporary
копаться. Если у вас
interval of rhythm
зафиксировано,
failure, and then
вопрос
you
не
need to
в повестке
analyze
дня.
more. If
Какая
it was
разница, что
fixed,
зафиксировало
then no
фибрилляцию
question on the
предсердий?
agenda.
Если я вижу
It
на
doesn't
ЭКГ
really matter
фибрилляцию
which
предсердий,
device
для меня диагноз
showed
ясен. Я
you
начну
AF.
терапию, мне
If
будет
I
только
see
лучше, пока она
AF, the
продолжается.
diagnosis is
Довольно
clear.
агрессивное отношение к пациенту. Риски инсульта и риски всего, чего
Stroke
хотите.
risk
Все то, что
and
мы
risk of
говорили.
anything you want is what we mentioned before. Let me participate participate in this discussion. Yes, of course. Gregory Pavlovich, I agree with you completely, but there is another problem here. Not always the level of qualification of a therapist who is making a decision is as high as yours. So very often I see the films that bring the doctors and say this is fibrillation or the atrial extrasystole and something else. This is number one. That is to say, we need to make sure that this is clearly AF. Secondly, the the duration of paroxysm should be at least 30 seconds. Even if we know everything about APEX, everything about risk factors, the very fact of non-identifying a 30-second episode is our headache. Even if it's 25 seconds, we should call it not atrial fibrillation, but multimorphous atrial angina. Because if you say AF, a person will be administered anticoagulant therapy, and if it was administered, it can endanger his life. Until we make sure that our suspicion is confirmed and it is atrial fibrillation, until that we have to spend time, money and nerves, but from the seeming obviousness, with a great number of risks and complaints on arrhythmia, we can't start this therapy without definitive diagnosis. Unfortunately, this is still an open question. Unfortunately, we still have a lack of absolute reliability in diagnosing AF. We need technical breakthrough to make atrial fibrillation better detectable by portable devices, to differentiate it well, to avoid mistakes. Thank you. I agree with you. May I join as well? Natalia Andreevna, just a second. I'll give you the floor. I heard a lot of conservative and skepticism in your response, Andrei Mikhailovich. The accuracy of mobile portable devices is almost as good as ECGs, but we know that fibrillation will start from a series of short paroxysms, duration 5-10 seconds. They will appear in nighttime. Formally speaking, we can't do anything about it until they get prolonged for 30 seconds. You know, Alexander Grigorovich, dear colleagues, I will join your opinion. I think a watch device gives us a huge opportunity to suspect atrial fibrillation. And if I have somewhere indicated that a patient hypothetically might have AF, I will calculate his CHA2-VASc score, stroke and thromboembolism, and it's high. I will take a note of this patient. I will refer him to long Holter ECG, because if I skip AF and will simply keep monitoring and it's a high-risk stroke patient, I will be guilty if the patient develops ischemic stroke or other thromboembolisms. So today, in our times, the attitude to watch devices and other portable devices that are implying possible AF in the patients with high risks of stroke, we should be more attentive to them than ever. And if a patient like this on Holter shows high risk of stroke and he will have 5 paroxysms in 5 seconds, not 30 seconds, I will definitely administer anticoagulants, keeping in mind that this time interval won't have a positive impact. I know it's shorter. So once again, if there's a high risk of stroke, we will evaluate this patient very, very carefully with watch device, and even the short paroxysms of AF will be assessed. Evgeny Mikhailovich, you disagreed? Yes, I strongly disagree, because there are rules to follow, and they exist for that reason. And I think that if we really step aside from the guidelines, simply because we have our own ideas about how things should be done. With all my respect to you, dear Natalia Andreevna, I understand it. I do understand it, but practically we're taking a risk of having no evidence of our decision. I think if 30 seconds were written down, Given the fact that I hate being a formalist, I have to follow this. And I will just again and again put monitors, I will catch this paroxysm, and I will do that. Evgeny Mikhailovich, I will join Natalia Andreevna's position. I share it in the times of COVID-19 pandemics. The entire medicine went to no evidence medicine, and in Russia, administration of high doses of anticoagulants saved thousands of lives in Russia, something which didn't happen in Europe. Alexander Grigorievich, sometimes no evidence really can give you a good luck under the control, etc. But how many negative effects can there be from no evidence administration of the drugs that were used in COVID? Not at all. It means that we need to shut down our whole medicine. If we take as a basis no evidence in medicine, we have nothing to do here. Yana Arturovna, what is your position? Are you more formal? Do you have a more formal approach of 30 seconds or a more aggressive position if there are shorter paroxysms that were fixed with high risk of stroke and thromboembolism? Yes, 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 of course. I'll try and find I'll try to catch longer paroxysms. While you are looking for them, ischemic stroke will happen. Come on, Natalia Andreevna, if bleeding happens, because of the drug that you are formally speaking administered only based on your intuition, what will it lead you to? As for frequency of stroke and frequency of bleeding, there's a difference between them. Yeah, I know, but we have rules. You know, I want to say that everyone can make a concilium in his institution and make a decision. But to recommend to a practitioner to act without of the guidelines is to put him in a very unfavorable situation from legal perspective. And of course, I think it's awful. I wouldn't find it comfortable. Okay, you are a professor, and the patient was brought to you 5 paroxysms and high risk. 30 seconds, you don't see it. What will you do? You are a professor and it's a concilium. 5-6 seconds, no. Myself, I was doing daily ECG monitoring for many years. 5-6 seconds, no. 20 seconds, 30 seconds, yes, but no, 5 paroxysms in a row. 5-6 paroxysms, 5-6 seconds long. I'll be looking for it. I'll keep monitoring. I'll be looking for it. These are high risks of individual people. Ekaterina Iosifovna, what's your opinion? Well, I do support the follow-up, the compliance to clinical guidelines, but you know, recently I had a similar situation and I realized that I'd rather support Natalia Andreevna's opinion. If Chartvask score is high and I have a man who has several short attacks, I just came to this idea that I will administer anticoagulants. That's my personal view. I don't impose it on anyone. It's just, yeah, I just try to explain why I'm doing this, although I believe that, yes, clinical guidelines is something we should all follow. It's very important. But here also there is a common sense which tells me that this man has a high risk of stroke and I need to give him anticoagulants, colleagues. What a heated debate. At the second question, I'd like more experts to express their opinions, because so far we have 50-50. 3 persons for more aggressive approach, 3 doctors against. Let me speak up, dear colleagues. As far as I know today, the guidelines don't specifically mention that detection of paroxysmal AF by means of mobile devices is a reason, given the risks, is a reason to administer anticoagulant therapy. Of course, we know that this technology is going to develop, and in the future, apparently, we will have these kind of guidelines. But as of today, if we are talking about detection of AF based on exclusively portable devices, that portable device that belongs to the patient, how do we document this paroxysm? It's an important problem. There's one thing if you did it on Holter. There's another thing if your patient comes and he shows you the paroxysm on the screen of his mobile phone. To administer anticoagulants based on this, de jure, is something we cannot do. But if he shows me the result of paroxysms in the first 30 seconds, I would say I'm more inclined to the conservative group of my colleagues who would rather not give than give anticoagulants to this patient if paroxysms were below 30 seconds. The opinion of one more expert. We have Alexey Nikolaevich. Your opinion, Alexey Nikolaevich? Really interesting discussion. In the continuation of Stanislav Sergeevich's words, I would say, yes, indeed. The portable devices, watches, don't register ECG. ECG is a complicated mechanism. We need to do ECG. And maybe the problems that were shown by some portable devices can be then confirmed by other portable devices or the skin unichannel machines can be used. And yes, indeed, sometimes medicine is taking patient side. Many times patients use these devices, these technologies, but why not use the devices that can give us quality information on ECG? And as for the discussion of anticoagulant administration, of course, we need to balance up the hemorrhagic risk, all the pros and cons. You know, I had experience when I had a consilium with other respected colleagues. The patient had 20-second paroxysm. He had a mobile device. We were catching this paroxysm for a long time. We caught it with Holter. Despite a marginal risk on CHA2DS2-VASc score, we decided to administer anticoagulant, but the patient said, no, I'm not going to take it. Of course, the priority belongs to the guidelines in this situation. We need to very cautiously expand the indications for anticoagulants, but an individual decision of this kind might be taken, and I was involved in it once. So the question is to carefully balance up all the pros and cons based on that particular patient and, of course, doctoral commission consilium. Okay, so this is not a decision to be made by one doctor, right? Always a consilium, always a balanced decision. Yana Arturovna, a therapist shouldn't take this responsibility. It's a matter of consilium. Catch the patient, realize that he's patient at risk, yeah, but then let the consilium decide. Thank you very much for your comments. I want to say regarding the last two speakers, Alexey Nikolaevich and Evgeny Mikhailovich, yes, indeed, these devices haven't been registered in Russia. They are approved, nevertheless, by FDA, Class 2 devices, registered devices. It's just not in Russia yet. And secondly, they are present in European guidelines, and according to the strategy, they need to fulfill and compensate the component. And they are ECG, they are registering ECG. It depends on the model of the watches we're talking about. There's also this cardio web system where the second point of information is the case, mobile phone case. So these are really, they do exist, these portable devices, but as you know, the opinions of the experts are 50-50. Let's go to the next question. Maybe it's less disputable. It's associated with pandemics. We know that with COVID-19, we have a rapid increase of the number of patients with thrombocytopenia. and anticoagulants are administered there. Let's split the patients in 3 areas. Thrombocytes are below 50, above 50, and above 50. 50 to 100 in this zone. What do you think, dear experts? Should the anticoagulants be given to the patients with AF and with that level of thrombocytes? Dear colleagues, Alexander Grigorievich, in fact, the answer to this question is given by the European Guidelines of Atrial Fibrillation 2020. It was said there that if the level of thrombocytes is more than 50 and below 100, the question of administering anticoagulants should be solved in a team, in an interdisciplinary team, with mandatory inclusion of hematologists and inclusion of other factors and thromboembolic complications and hemorrhagic risks should be tackled by interdisciplinary team with thrombocytes from 50 to 100. It's the multidisciplinary team that should make a decision. So this is a very personalized approach to each patient alone. Unfortunately, we don't always have a hematologist available. Yeah, of course. Dear colleagues, this matter from the very beginning of COVID-19 pandemics have been raised in all guidelines and cardiac societies that deal with coronavirus infection, and there were guidelines of the European International Society on Hemostasis Failures. COVID-19 infection entails high risks of micro and macro thrombosis, and all these percentages don't fit in our schemes where coronavirus infections are not considered. The risks are high from 50 to 100, and therefore anticoagulants should be administered. Counterindications are level of thrombocytes below 20,000. Even with a level 25 to 50,000, patients with coronavirus infections are recommended to have anticoagulants. Thank you, Yana Arturovna. Of course, we were also struggling to understand what to do, and I fully agree with Ekaterina Iosifovna. If until 25 they administer maybe a reduced dose, not a full therapeutic dose, but keep in mind that there are some anticoagulants that can be a bit more safe in this situation. Thank you for your comments, Yana Arturovna. I wanted to bring you a similar example. It's hard to find a hematologist in red area zone. We faced this need, patient with 6 thrombocytes. This was the real figure of thrombocytes, and anticoagulant was anyway administered, sodium panabrinax. It's a hard category of the patients. Patients with milder course of disease, yes, the step is from 52 up, and maybe it is justified if we continue anticoagulants. We'll go to the next question. Well, I want to add here that we can't consider separately thrombocytopenia. Why? Because imagine that this patient, apart from thrombocytopenia, has 5 more hemorrhagic risk factors, and we are giving him anticoagulants. So for one criteria only to decide to give anticoagulants or no, even with coronavirus, we can't do this. We need to cancel all the factors of hemorrhagic risk and then say yes or no. This is important not to damage. And let me add that in our guidelines written by the Eurasian Association of Therapists, it is written so that assess it in complex based on the risk factors of hemorrhage. I can only add, I fully agree. Sometimes it makes sense that to evaluate the thrombocyte function. If these tests are done, it helps to make decisions. Fully agree. Small comment from a neurologist. In 3 studies with DOACs and COVID, patients with thrombocyte level below 100, we didn't have them. It's a narrow zone from 50 to 100, yes, especially in COVID. We should consider the NOACs, yes. Dear colleagues, imagine that we administer thrombocytes where 70, 60 doesn't matter. We have the concilium, we administered, and the patient has persistent bleeding, hematuria. He tells you about it or you detect it randomly during checkup. What is the tactics of actions? We discussed subcutaneous hematomas, gum bleeding, nasal bleeding, hematuria. What should a practitioner do? Of course, we need to examine the doctor. Anticoagulant make some situation worse. You just need to detect it. So what is the strategy the therapist should undertake? Colleagues, we had this situation, I can easily discuss it, and we face it. I tried to be first one to speak and then ask the urologist if we were right or wrong. The patient who didn't have a high risk of thrombocyte platelet reduction, he had a severe course of COVID and he had thrombotic complications and he had hepaturia. We did cytoscopy in this COVID clinic and we saw hemorrhages from his varicoses affected veins in the area of prostate gland, and we conducted local flush and some local events to stop this bleeding. The dose was moved from therapeutic to preventive, but we didn't cancel it. What if you are talking about perioral anticoagulants without COVID? Without COVID, I would first of all do cystoscopy and look for the source of bleeding. Maybe some varicoses veins or maybe bladder cancer. Bladder cancer. 80% higher the probability of hemorrhage. I would also be based on the word. Hematuria is a visual diagnosis. The color of urine should be changed. These are not erythrocytes. Hematuria is a changed color of urine. Because if you have erythrocytes, it's okay. Come on, they don't impact. In our case, Gregory Pavlovich, we had clots. Yeah, clots. It's another story. So we didn't cancel, we coped locally. Dear colleagues, for further discussion on this question, let's differentiate between microhematuria from macrohematuria, which may require cancellation, reduction of dose, or full cancellation of anticoagulants for the follow-up period, and the consolidated position of Eurasian therapeutics say if there's macrohematuria, then the anticoagulant should be stopped until further finding of the reason and further follow-up. Does everybody agree with this approach? Yes, absolutely. Then let's go to the next question. And the next question is quite an interesting one. We know very well that antidotes of monoclonal antibodies, antidotes to one of the DOACs, became a way to timely stop the hemorrhagic risks in a patient because of a trauma or the upcoming bleeding. Can the very fact of an antidote be a relevant requirement for the administration of DOAC in atrial fibrillation? Or can it be a drug of choice? What can I say, dear colleagues, about it? to deny the use of specific antagonist is not reasonable. There is a significant statistics published in the American Journal in 2017 saying that it's a large statistics, over 100,000 patients where the repetitive secondary cerebral ischemic events despite anticoagulant therapy were studied. It was shown that 9% of the patients taking DOACs, despite this, did have ischemic strokes. For these 9%, the specific antagonist may be relevant. For others, it's not important. Why is this relevant? Because having a specific antagonist, we can do a systemic thrombolytic therapy if he is in the therapeutic window. This is my opinion. Okay, Stanislav Sergeyevich, did this population differ from others, this 9%? Were they unique? No, they were not unique. They weren't. These are patients who were taking perioral anticoagulants, but ischemic stroke happened not necessarily because of anticoagulant. The patient, apart from compliance, may have other diseases that, irrespective of atrial fibrillation, may lead to ischemic stroke. But there's another question. Patients who had ischemic stroke with optimal anticoagulant therapy and they have AF, they have it on a much more rare basis. Severity is less and mortality is less. So in any case, if the patient gets anticoagulant, he has better outcome. They had a comparison with outcomes of the patients who didn't take anticoagulants or those who took warfarin or who took aspirin, 3 populations. And it was shown that if the patient takes warfarin less than 2 or aspirin, or he doesn't take anything, the outcomes are much worse than the ones who are either on warfarin therapy or are highly compliant to DOAC therapy. This was the content of the article. Thank you so much, Stanislav Sergeyevich. And the next question, if nobody else wants to speak. Well, yeah, but what is the conclusion we are arriving at? I didn't quite understand it. Is there an antidote or not? It should impact my decision, right? Dear colleagues, look, antidote. It's important to know that we have idracizumab's antidote, dabigatran, we know its cost, we know that it's not available, at least in Perm for sure. So will the drug impact on my choice? Will this antidote impact my choice? No, because there's zero availability of antidote in Perm, and even if it is available, it will be affordable to very few people, and so it won't impact my decision on anticoagulation. The very fact that there is antidote is wonderful, and theoretically for some patients, someday I will have this opportunity to stop the bleeding and to do a timely heart transplantation, for example. I agree with you. Let's be close to the real life. Yes, I fully agree with Natalia Andreevna. The situation in Perm is not unique. We have the same. I guess we all have it almost everywhere in Russia, including Moscow. From the opinion of the experts, I saw some alignments that yes, it's cool, it's great to have an antidote. It is helpful in many cases, but the combination of accessibility and broadness of its use are not making it mandatory for the choice of our oral anticoagulant. Right. Next question, and it's not just a question, it's a large group of questions, and more than 100 of them aspects of managing the patient before and after PCI, double, triple therapy, duration of this therapy. Alexei Nikolaevich, can I address this question to you? Rivaroxaban and specifics of its use. Double, triple therapy of a patient with AF after PCI. How long? When do we cancel it? What is the tactics? What is the algorithm? I know you are an expert. Yeah, it's quite simple here. The recent version of European guidelines on treating AF makes it stricter, the rules of hemorrhagic risks. And if in the previous versions of the guidelines, we discussed a period of triple therapy when the patient, in addition to perioral anticoagulants, rivaroxaban, they needed acetylsalicylic acid and antagonists of beta-2, and preference was given to clopidogrel. At present, the new guidelines support minimization of triple therapy period, and routine practice is to administer triple therapy, DAPT plus anticoagulant only in perioperative period. Later, it is recommended to use perioral anticoagulant, primarily clopidogrel as well, among the patients with acute coronary syndrome that are undergoing angioplasty. They take it for up to 12 months with further shift to monoperioral anticoagulant. And if the patient is undergoing PCI monotherapy, it can be possible 6 months after. Perioral therapy with high-risk factors, anatomic, thrombotic, periprocedural risks that are associated with ischemia. These patients, the timeline of triple therapy can be prolonged in them, but the new guidelines restrict this period down to 1 month. At the moment, triple therapy, administering of aspirin with clopidogrel and a perioral anticoagulants for more than 30 days is not recommended after PCI. What is your attitude to the position of some experts who in small studies, in publications, demonstrate some advantages? 2, 3, and more years. This is a complicated question because there are no large studies that evaluate hemorrhagic and ischemic risks. Some sub-analysis and some studies say that many got additional disaggregants, but in this situation, on the other hand, we have proof in the meta-analysis. The meta-analysis that we analyzed, quoted with Evgeny Mikhailovich, saying that monotherapy with rivaroxaban as well is not worse than acetylsalicylic acid and warfarin. Despite MI, thank you very much. 5 more minutes for a Q&A session because we have 2 important questions. A question to Yana Arturovna and to Ekaterina Iosifovna. Can we, based on the follow-up study results, say which POAC will be, DOAC will be safe in this or that situation? Is it possible? No. Maybe we should explain what FORTA is, because not everybody knows. FORTA, Euroforta, American FORTA, it's a consensus document. It's a consensus document based on the Delphin consensus principle. The experts come together, they discuss which drugs have a better ratio of efficacy and safety, whose balance is worse among elderly polymorbid patients. And code A, for example, Code B in this consensus belongs to other DOACs and warfarin. Wait, Ekaterina Iosifovna, 4 of different periods. Code A was given to rivaroxaban, apexaban, and during the period between those consensuses in Forta in different years, no new studies were conducted. I want to highlight that these are consensus documents. These are the opinions of the experts. Well, the last version of this system was apexaban. We have discussed it. We conducted it at the Congress of Cardiologists. Our consensus of experts, if it would gather, we would set our priorities slightly differently. And of course, here we need to rely on the evidence base that we have. Was it only on the follow-up studies about Forta? Well, it's a mix, isn't it? Well, you know, yeah, they were looking at the observational studies, but we need to assess also the randomized control studies and observational studies. Then we would probably have a different focus on these anticoagulants. I don't know how exactly, but still. I want to say that in the conclusion, it's not evidence-based class A or B, it's C, and let's keep it in mind. Yeah, of course, of course. Dear colleagues, may I add something? We are speaking about observational studies and randomized clinical studies. The pyramid of evidence base is randomized clinical studies, and we're talking about elderly patients here when speaking about Euroforta. So, dear colleagues, today there is the only randomized clinical study comparison of NOACs, edoxaban with warfarin, elderly patients, that was completed this year, and it was presented at the European Conference of Cardiologists. So the highest evidence class of the randomized clinical studies, I would say only edoxaban is there, but you will agree that there are some risks. If my elderly patient takes any new NOAC and is compliant to this treatment, I would be simply happy, because we can't disregard the correctly conducted observational studies where patients of elderly age, rivaroxaban and any other NOACs showed their efficacy. I think today we, for this category of elderly patients, should consider this. Well, you know, if we compare sub-analysis and comparative studies, sub-analysis will be higher than observational studies. There are lots of sub-analysis with elderly patients above 75, 80 with rivaroxaban as well. So this is very important. We can and we must consider this sub-analysis. Yes, we must. Of course, we must. You know, old age is very important. If it's above 2000, we understand that the value and accuracy is very low, but the observational study, when hundreds and thousands of elderly patients are observed, there the accuracy is higher. Rivaroxaban above 75, several thousand people, 2.5 or so. Yeah.
Эта популяция всегда ограничена, потому что это пожилые пациенты. Без сомнения, она требует дальнейших исследований. И я предлагаю перейти к финальному
I
вопросу.
suggest to go to the
Вопрос
final
очень простой.
question.
Это вопрос,
It's
который
a very
многократно
simple
с разных сторон
question.
затрагивал те инновации, которые
It's a
появились в
question
новых
which from many
рекомендациях
sides
ESC, касаются
was
корреляции
dwelling
предсердечно-естественной.
upon the
Я бы
ESC
попросил сейчас каждого
innovations
эксперта по
in the
очереди
new
сказать,
guidelines
что
on
нового из этих
AF
рекомендаций
patients.
произвело на
I
вас
would like to
непосредственно
ask
ваше
each
личное
expert to
мнение.
say
Самое
what
большое
are the new
впечатление.
things in
Что
these
конкретно
guidelines
с
that
вашей
impressed
точки
you the
зрения самое
most. What
значимое? Я позволю
exactly,
себе
from
высказаться
your
первым.
perspective, was the
Я
most
позволю,
relevant
можно и
thing?
негативное
May I
впечатление.
say
Без сомнения,
something
мы обсуждаем
negative that
новое.
impressed me?
Поэтому как
Yes,
положительная, так и
we
негативная
are
реакция
discussing
будет
the new
уместна и
things,
будет
both
интересна.
positive and
Я
negative.
позволю себе как
We're
ведущему
interested in your
высказаться
feedback,
первому,
whether it's
и я
positive
скажу,
or
что для меня
negative.
самым
I'd
ключевым
like
является,
to
наконец, признание и появление, то, о чем сегодня говорилось в самом начале,
say
носимых устройств,
that
ссылки
for
на
me
эти
the key
исследования,
was the
использование
recognition
этих
and
данных для
emergence of portable
ведения
devices,
пациентов по
references
протоколу
to
ABC,
these
который без
studies,
сомнения
and conduction
многократно улучшит
and
прогноз и
management of
качество
these
жизни этих
patients
больных.
according to ABC
Признание
protocol
того, что
that will
технологии
significantly
входят в
increase
нашу
the
жизнь,
quality of life
является в
of
данной
these
ситуации
patients.
ключевым. Но
The
я попрошу
recognition
каждого
of the
эксперта
fact
сказать
that
лично свое
technologies are
мнение,
entering
очень
our lives
кратко
is the
коснуться
key.
того, что нового понравилось или наоборот не
I
понравилось.
would like to
Давайте
briefly
начнем.
ask
Давай
you
в
to say
алфавитном
what you
порядке.
liked and what you
Да,
disliked.
пожалуйста, в алфавитном порядке.
In
Я
alphabetic
скажу
order,
два
please.
момента, которые на меня
Let
произвели
me
большое
say, alphabetically, we have two Arutunovs. Who is a priority? Well, two things that impressed me the most. First thing is the recognition that AF is not just a rhythm failure, but it's a socially relevant disease. So we have a patient-centristic principle in 4S model. It's not just vain talks, but a complex approach to the patient. And the second imperative statement is the high risk of bleeding, which is not a criteria for cancellation or the non-onset of perioral anticoagulants. These two things that were talked a lot about, but nothing was done. Last but not least, it appeared on the level of guidelines. Natalia Andreevna, I want to mention something negative. The positive thing is I'm very happy that finally the new guidelines convey that the clinical model of atrial fibrillation, paroxysmal, persistent, permanent, is not a criteria for the administration of anticoagulants. The criteria is the risk of stroke. And for the first time, with the level of evidence 3A, it's highlighted in the guidelines. And it's not the model of AF, but the very fact of the stroke risk. And the negative thing is, Stanislav Sergeyevich mentioned it today, dear colleagues, we have developed, we have worked so much with dinner strategy or for so many years when to, or how to handle the patient with stroke. And today we suddenly have to give up this scale, dinner scale, that was so convenient. Although in the new guidelines, nothing have been changed for 14 days. And now we want the doctor to shoulder this responsibility again and define himself again, to give in 4 days or not to give in 14 days or not to give. I think these guidelines are of recommendational nature, and I think a dinner strategy can have a place in our practice. Natalia Andreevna. Well, Yuri Pavlovich, we should move on. Ekaterina Iosifovna. Well, myself, I like a well-aligned table on the risk factors of hemorrhages, more detailed and better elaborated and discussed table of the bleeding risk factors. It is more specific. And second thing is, after PCIs, there's a direct recommendation to have a two-component therapy, anticoagulant and antiplatelet drug as a routine clinical practice. So the sharp reduction of triple therapy period, which is something the doctors have already been doing in real clinical practice. Thank you. Alexey Nikolaevich. Well, in fact, this position has already been raised. Indeed, patients with ischemic heart disease, ACS, it's quite an unambiguous position regarding some groups of patients. When we have groups of patients with a risk of MI, with double therapy is higher, and we can even imagine who those patients are with anatomic characteristics. But again, the focus on the patient, the safety of patient, new technologies, new generations of stents, it all goes to the situation when we are treating the patients more and more cautiously, despite the fact that our intervention becomes safer and more efficient. Thank you. Stanislav Sergeyevich, your position. What I liked, with great pleasure, I saw that HASPLIT score came back to our real clinical practice. Well, it didn't, in fact, go anywhere. We just, it was just forgotten for 4 years. They were announced in 2016 in Rome. These guidelines have been revised for 3 times in the last 10 years. I agree with Natalia Andreevna, who spoke about dinner score. We don't have it today. We understood, of course, that this is not evidence-based medicine. It was empirical, but it helped us to navigate in administering anticoagulant therapy. One thing that makes me uncomfortable when I read those guidelines is we have a new figure there from the perspective of administering anticoagulants in case of hemorrhagic stroke, 2 to 4 weeks. All the data regarding safety of this 2-week administration are only based on a publication of 2018, 137 patients in Germany, and they were talking about renewal of vitamin K antagonists among the patients with mechanical prosthesis after hemorrhagic stroke. I suspect the figures are from there. The guidelines of 2020 and the source of these 2 weeks, it's not quite clear. In any case, I believe that the special, I still believe that it's 4 to 8 weeks in overwhelming majority of cases. Thank you very much, Yana Arturovna. Thank you, colleagues. I fully agree with everything you have mentioned before. Maybe my comment is a bit emotional. I don't like very much that HASPLIT score came back, because very often in real clinical practice, I face the situation when a high score in HASPLIT doesn't lead to a more attentive attitude to the patient, to more frequent checkups or examinations, or more intense evaluation of modifying, non-modifying factors. Because the score, when you calculate something against the score, this level should entail a certain decision. Chatuvasc, 0, you don't need to administer. 2, you need to administer. HASPLIT, in fact, any number of scores doesn't prohibit or doesn't require a non-administration. So, in general, an approach that was associated with the evaluation of modified risk factors or an attempt to modify them for better was more accurate in my opinion, but I'm not insisting. And one more thing. I don't like HASPLIT only because very often in real life, it becomes a reason for non-administration of anticoagulants or reduced doses, and in cases when it's not justified. This is something I don't like. Second thing I don't like, if you remember the American guidelines on AF, 2019, they clearly say that NOACs have advantages, 1A class evidence in comparison with vitamin K antagonists. I expected to see something similar in European guidelines, but we didn't. In Russia, we conducted active data study. In Russia, TIAM was 52%. In real clinical practice, I don't think anybody knows about it. So it's clear that we will be using vitamin K antagonists for economic reasons, first of all. In all other cases, when it's not a question of mechanical prosthesis or some direct indications, and when finances are not of importance, no acts should be administered. I'm sorry, Yana Arturovna, I fully share your opinion on Hasblat and the use of POVAC, non-POVAC, and let me give the floor for final position to Evgeny Mikhailovich. Your opinion? Dear colleagues, you have told everything from what I was planning to say, so I only want to add, maybe it's good that the new guidelines are focusing on the central position and they put patient in the center. It's his disease and he should be involved in decision making first of all, because without it, we won't say. I don't like that in the risk factors it is directly said, well, we should think about our professions and our hobbies. I know a person who is taking anticoagulants, but he's also an active skier. We should keep it in mind. Thank you. Dear experts, dear colleagues, thank you very much. Dear experts, don't shut down your cameras because now we are going to the Zoom rooms with Q&A sessions, and all the people listening to us, you are invited to go on Zoom.
Zoom-комнату также прописана там, она есть на чате, и вы можете задать вопрос в чат технической поддержки. В любом случае, переходите, потому что там будет
In any case, go on Zoom because we will have a live discussion and the speaker will give questions to your written or verbalized questions. This session will last for 15-20 more minutes.
Когда можно задать вопросы спикерам в Zoom-комнатах. Я приглашаю всех перейти туда, потом мы уйдем на перерыв, и потом вернемся к работе на симпозиумах. Уважаемые коллеги, переходим в Zoom для сессии вопросы-ответы.
В ваших руках возможность замедлить прогрессирование хронической сердечной недостаточности. Какова цена промедления?
Да-да-да.
Я пока не могу изменить этот аккаунт, он мне еще нужен.
Ага, я понял.
Я боюсь сбить настройки, иначе я тогда не свяжусь с иначе будет
Не, ничего
конференция.
страшного.
Так что ничего, привыкайте. Что я Ида временно. Спасибо.
Так, сейчас я вам
Да, жду, когда вы назначите меня переводчиком. Огромного перевода 1-2. Английский канал синхронного перевода 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Английский канал синхронного перевода Евроазиатская конференция ревматологов 1, 2, 3, 4, 5, 6, 7, 8. Нормально все?
Счастье быть с близкими, вести активный образ жизни, делать то, что хочется. Как редко мы задумываемся о ценности здоровья. За видимым благополучием мы не сразу замечаем серьезных изменений. Пациенты с хронической сердечной недостаточностью попадают в водоворот дом, поликлиника, стационар. В ваших
Patients
силах вовремя
with
предложить им помощь.
CHF,
Какова цена промедления?
you must help them. There should be no delay when the ejection fraction is less than 50%, even at the initial stage of systolic dysfunction, tells us about the processes of myocardial remodulation. The problem is a neurohormonal disbalance. Heart chambers increase in size, the ejection fraction drops down. This leads to the lower perfusion of the organism in the myocardium. There are more fibrotic processes and there is more connective tissue share, which leads to the foci of electric instability and the risk of sudden death. Heart chambers increase, the heart muscle loses elasticity. The process of myocardial fibrosis takes place in case of systolic dysfunction and CHF, even at early stages. According to the study, patients of class 2 are in the high-risk group of sudden cardiac death. The 5-year survival prognosis of patients with CHF is comparable to many cancer patients. That is why when systolic function is detected when the ejection fraction is less than 50%, you should immediately think about the optimization of therapy. Today there are lots of opportunities to reverse the remodeling process at the early stage of the development of systolic dysfunction. That means longer life of the patient with a high quality of life, a protection against the risk of sudden cardiac death. The studies have shown that the use of modern therapy allows to reduce the process of myocardium fibrosation. You can see SST2, well, you can up the ejection fraction by 10%. Cyclomitril therapy of Volsitran can give good results. The Czech paradigm showed that more than 10% of class 2, well, we had very good results. There was the risk of sudden heart death, which was significantly reduced. Any patient with ejection fraction of less than 50 can get modern therapy, and this will improve the situation with the risk of sudden death. Well, Professor Rutunov, our announcer, has told us everything. Well, dear colleagues, let me just say that it's the second day of the 10th International Conference of the Eurasian Association of Therapy. Well, we have discussed how the pandemic has changed our future. We discussed it yesterday. At the end of the day, 7 countries, 7 experts. We asked you to discuss issues related to heart failure, antibacterial therapy in the era of the pandemic. We also raised the issue of the use of anticoagulants in a wide range of cases. There was a Q&A session. There was a discussion how to use anticoagulants in patients with COVID-19. Naturally, this topic will be raised at other symposia. Right now, after the break, I'd like to say that we will have 3 halls working: Moscow, St. Petersburg, and Perm. As for the Moscow hall, there will be a big symposium devoted to heart failure. Well, pump tube filter, that's a very modern approach to heart failure. In St. Petersburg, there will be a symposium devoted to arterial and venous thrombosis, where experts will be able to discuss the different aspects of the use of anticoagulation prophylaxis for patients not only with venous but also artery thrombosis, because COVID-19 has expanded the horizon for the development of arterial thrombosis. In the Perm Hall, there will be the first of the 2 symposia. I'd like to draw your attention to it, devoted to COVID-19, where there will be a discussion on lung damage, also cardiovascular system, myocarditis, we mentioned it yesterday, and finally, kidney damage in such patients. We'll be also talking talking about immunity and infection. And now I suggest all participants choose the symposium which is the most interesting for you. As for the Moscow Hall, this symposium is devoted to CHF, chronic heart failure. What's the modern algorithm? Because chronic heart failure is the end stage of the heart pathology. I'd like to give the floor to the first presenter, Grigory Arutyunov, chronic heart failure and chronic kidney disease. The focus on the filter. Well, let me just explain what is meant here. Pump is the vessel, filter is the kidney, well, and the filter is the myocardium. So we raised the problem of CHF, which is a serious problem for us. In Russia, we have 4.5 million patients with CHF, chronic heart failure. That means 9 in 10 of these patients will be hospitalized once a year. Every sixth person in the hospital has problems with circulation. That's a very relevant problem. The first global issue is the ejection fraction. For a long time, we had the rigid scheme. Low EF is less than 50%. To preserve the 50, in the middle is the intermediate ejection fraction. I'm not going to go into different arguments, but as for the interval from 40 to 50 is considered as the initial stage of low ejection fraction. It looks like it's a plain words, but it's a major step forward because with this intermediate stage, we can talk about patients who can get drugs which are quite effective in terms of patients with low ejection fraction. That's an important step forward in treatment of our patients. Look at the 50% indicator of the ejection fraction, less than 80. Well, you can see the yellow arrow goes up, and it says that the risk of death starts to grow. That means there is a watershed at the level of 50% of the ejection fraction. That's important for us, but there is a higher percentage of patients that will be covered by our services. Here is this fashionable trend, pump, tube, filter. Well, the idea is very simple. There is no just CHF or chronic kidney disease. Well, all the vessels will be affected at the same time. If we're talking about a drug, well, the drug should be equally effective or will have the same impact on those parameters which we attribute to the pump, to the tube, and to the endothelial or the wall. And thus, the new principle is that the drug should be effective concerning all these three aspects, pump, tube, filter. The first person who talked about this trichotomy was Richard Bright. In 1831, he analyzed the results of the kidney disease. These were patients who, during their life, he found a protein. When he boiled urine, he found hard myocardium, thickened myocardium. Richard Bright wrote about this, but he made the connection between the kidney and the myocardium. As for the more modern concept of cardiorenal syndrome, and usually this syndrome happens in patients with heart failure, has 5 aspects. The most important type is type 2. What is type 1, by the way? That's the acute condition. The heart function deteriorated significantly, and the kidney function deteriorated. Type 2 is a chronic patient, a patient with insufficient blood circulation, and there has been a reduction in the pumping function, and this has led in the change of the blood flow through the kidney. The kidney structure changed. The type 3 and 4, that's the opposite situation. Well, acute renal cardial problem. Type 4 is the chronic renal cardial. Type 5 is in between, like sepsis. How does it affect the clinical trials? That's what we tell our students at medical universities. They should have a clear understanding of these terms. MACE, well, has been around for quite a lot. That means the pathology of the cardiovascular system. It's a combination indicator, such as cardiac death, non-lethal MI, non-lethal stroke. Well, also here is MIC, that means increased creatinine, that means increasing parameters in the kidneys, that means hemodialysis for the patient or kidney transplantation. But the modern approach required the combination of these parameters. If we're talking about pump, vessel, and the filter, in this case, MARS, has been introduced. Well, that means major adverse renal and cardiac events, as you can see it here. So we need the drug to have effect on two organs. When we're talking about the kidney conditions, and this structure is recommended by KDIGO, you can see here the comparison with plants. They belch smoke, but they do it more and more. Well, glomerulus are in the mode of hyperfiltration, then they die, and then everything depends on the number of functioning glomerulus. Well, you can see the progression of CKD. Every year we lose 1% of glomerulus, and soon they will be like that, and there will be no new glomerulus. Patients with CKD have a lesser number of functioning glomerulus. It's called absolute oligonephronia, because for patients with CHF, that's one of the leading processes. Knowing absolute oligonephronia, we can calculate the glomerular filtration rate, because the choice of the dose of the drug is determined by the glomerular filtration rate. What is happening with glomerulus which are not affected? Well, look at their size. They start to increase. There is the hyperfiltration process starting another process in patients with CKD. Well, you shouldn't know the details of pathophysiology, but you should know the principle. Well, the figure, that's the outflow artery. It is very narrow. The renin-angiotensin system function is diminished. There will be a spasm, a trap. The blood comes but cannot go out because of the spasm. The loops will be filled with blood. Inside the glomerular, there will be high pressure. Well, loops start exerting pressure on the filter of the kidney. The electric charge changes, and albumin molecule starts getting into the urine. It doesn't come back, and in this case, we overstepped the red line. The patient with microalbuminuria changes its forecast. The outcome will be much worse. In this case, the task is very simple: to remove the high pressure inside the glomerulus. How can I do it? I can basically use a sartan or calcium agonist, but what can I do with the artery that brings the blood in? Well, maybe I should ask you a question, because especially patients with diabetes mellitus, well, who controls the tone of the artery? Who controls the volume of blood received? And of course, these purple fields, that's collagen. It depresses the artery, and again, you can see what the process is, and you can see the patient with the shortness of breath. Again, what is happening with the kidney right now? Well, that's just one figure. Glomerular filtration rate, GFR, determines the condition of the patient. There are different formula. Just look at the formula called CKD. It is universal for our patients, but there are also limitations for the universal formula. A patient without an arm or a leg, a vegetarian, with the worsening of the kidney function, you cannot use this CKD function formula. Unfortunately, it doesn't work. What should be done in this situation? Of course, in this case, we should use Berger probe. In this case, we should not use creatinine. We can determine the antigen and determine the GFR. And of course, it's a cystatin C. And thus, in real life, we don't have a patient who cannot have a GFR calculated. What do we know? Managing patient with CHF. If GFR less than 60, there is a higher risk of pathology. Well, less than 45, the risk of progression of kidney pathology can increase. Again, when the patient is in the blue zone, when your GFR less than 30, again, think about administering any drug and the dose of any drug, and do not do it until you know how the dose changes when GFR is less than 30 milliliters per minute. There are many drugs which are not recommended here, but other drugs should be adjusted in terms of dose. Well, in modern cardiology, there is such a notion that is used right now, and it's worsening of the filtration function of the kidney. Well, you should see how GFR drops. If it's more than 5 milliliters per minute, that's a critical situation. As for patients with CHF, well, CHF increases twofold the development of CKD, twofold, as you can see it, and CHF also increases the drop in GFR. See here, the patient had decompensation. He was discharged, and you can see that during hospitalization, GFR dropped, and the patient may have other congestion conditions. The red line shows that the future of this patient is very poor. The risk of death increases 2.5 times as compared to those patients who didn't have a CFR dropped. And also you can see the level of albumin lost. Well, we can say that we can use the screening method, the strip, or the lab tests, but when it's 3 to 4, well, you should know exactly how much protein the kidney loses. Here, the sympathetic renin-angiotensin-aldosterone system is of key importance. It changed everything. The myocardial and kidney condition, does the nature has some counterbalance. Well, pro-BNP should be such a counterbalance here. In this case, pro-BNP starts producing natriuretic peptide. That means together with natrium or sodium, water will be gone. And pro-BNP are good, but they live for a short time, just several minutes. And there is an neprilysin that destroys BNP. Can I have an impact on neprilysin? My goal is to increase the life of pro-BNP. Well, sacubitril blocks neprilysin. If I block neprilysin, pro-BNP will be living longer, but that's not exactly so. What's the problem? Why should we combine this drug with another one in one pill? We must have a clear understanding that fertile patients, well, BNP system has a counteraction toward the renin-angiotensin-aldosterone system. Well, BNP will protect fibrosis and the left ventricle hypoplasia. Sodium will increase. The renin-angiotensin aldosterone system acts quite differently. I blocked this system and the degradation of angiotensin 2 and bradykinin no more degraded, and that might lead to their accumulation and edema. Naproxen and valsartan can give us a very good result. Xorixatributrin and valsartan. In this case, we have a totally different molecular complex, which is called in Russia euteria. And in this case, life expectancy of BNP increases. Again, you can see the yellow line. It's at the proximal channel. I reduce the sodium reabsorption. If we have less net sodium returned, in this case, more water will be gone, and then the edema will be reduced. That is why the pump will be functioning better, because the load on the pump is less. The congestion volume is diminished. At the end of the 20th century, a study was conducted when BNP was introduced intravenously. The volume of urine increased, and now the question I ask you, who is going to have an impact on the afferent artery? Again, you can see it's in the upper part of the wide vessel. You can see the size of the glomerulus. Patients who had just one indication, diabetes mellitus. Now, for this class, there are more indicators, like dapagliflozin, for example. Another indication is insufficient circulation. If SGLT2 inhibitor is administered, sodium cannot return back. There is no exchange between glucose and sodium. Sodium cations in a large amount gets into the Henle loop. Maculodense defines the tone of the afferent artery. When there are a lot of sodium cations, the volume of blood along the afferent artery is reduced. Sort of the reduction of the glomerulus, there is no hyperfiltration anymore. You protected the glomerulus, and that means a new approach to management of patients with insufficient blood circulation. You can look at two fundamental columns. That's ARNI. As you can see it here, there was a drop in the number of patients who were put on ARNI, and the second column is SGLT2 inhibitor. What about the nephroprotective actions? SGLT2 inhibitors showed nephroprotective action. When I'm talking about EUPERIA and APF inhibitors, usually I do the comparison by way of GFR. EUPERIA is more effective than the use of neoprene. At least the glomerular filtration rate is different. EUPERIA slows down the kidney condition, and this is the breakthrough that we should talk about. EUPERIA started treating terminal chronic kidney disease, and that's very serious patients. The disease is at the chronical stage, at the terminal stage. Well, there was the growth of GFR, and the kidney function improved, the fibrotic process diminished, but what is important, you protected the kidney, the filter, and the pump. That's a very interesting aspect. Another study showed that by protecting the pump, you improved the myocardial markers, because you're talking about the long-term prognosis for this patient. Finally, this is the sub-analysis. We can see Euperia, the green line. You can see ACI inhibitors at the red line. And again, the follow-up of 5 years, you can see that the red line is lower than the green line. Euperia is higher. That means the more neuroprotective effect. As for the kidney, well, Euperia demonstrated very good results. Here you can see the peculiarities of administration of this drug. We're talking about severe patients when GFR is less than 30. That's at the bottom. The starting dose is 50 milligrams going to the pump, but there is just one aspect where Euperia is working when we're talking about the pump. Look at the two vertical lines, Euperia's effect as compared to other drugs in the combination analysis. Wonderful results. You can see it along the entire ejection fraction, up to 57% of ejection fraction. Two studies, Euperia with patients with mitral regurgitation. Dear comrades, just imagine you are listening to the first point of heart auscultation, the heart murmur in the axillary area. Patients who have mitral regurgitation, Euperia was administered to such patients, and you can see at my hands, the left ventricle is the globular-like ventricle. After Euperia, it became much less. The pressure in the left ventricle dropped, in the left atrium dropped, and now you can see reverse remodeling. The second study shown here, if that is so, in this case, NT-proBNP should drop, and that is true. You can see that there is the drop of NT-proBNP on the second week, and it doesn't go up. So this drug has the long-term impact. That means a reverse remodeling after 6 and 12 months. You can see that the patient has an increase in the ejection fraction. What is less than 50, in this case, the death curve goes up. If the ejection fraction is 50 and even more than 50, the risk of death is diminished in such patients. So this reverse remodeling is the unique ability to have an impact on pump field and vessel. Okay, there are retrospective trials. Well, you can see DAPA-HF, ARNI, and SGLT2. There were more results when empagliflozin was administered. Empagliflozin showed very good results. And at the bottom, you can see the circle is too far away. The combination of two drugs was the most effective, and recently the meta-analysis was published, comparison of treatment of patients, ARNI, the base drug, beta blockers, and SGLT2 inhibitors as compared to the traditional therapy. Look at the red field. Well, in 80-year patients, life expectancy rose by 1.4 years, and patients who are 54, 55 years had 6 additional years of life. Thus, comrades, we have a new ideology, such as reverse remodeling. Well, pipe filter pump, the nephroprotection, which leads to the preservation of glomerular filtration rate, and this new area which allows us to look at the future with optimism in treating patients with poor circulation. Thank you so much for your attention. And now I'd like to give the floor to the host. Can you hear us in your studio?
симпозиуму, посвященную проблеме сердечной недостаточности. И сейчас мы
Well,
затронем
this is
симпозиум.
the
Это
symposium
докладчик Анна
devoted
Ивановна,
to
профессор,
heart
доктор медицинских
failure.
наук. И
Now,
Анна Ивановна поделится
Anna
опытом
Chesnikova
пациента
is
с
going to
КСН
speak.
и
She's a
сахарным
professor,
диабетом второго типа.
PhD in
Вопрос
medicine.
того, как
Patients
запутаться в
with
приоритетах защиты сердца. И,
CHF and
насколько я понимаю, мы
diabetes
готовы
mellitus
вывести спикера на
type
экран. Анна
2.
Ивановна, передаю вам
So we're
слово.
ready to see the slides. Anna,
Прошу
the
прощения.
floor is yours. Thank
Итак,
you
давайте
very
коснемся
much.
вопроса. В чем загвоздка, в чем приоритет
Well, the
позиции
question is
КСН на диабет второго типа? Приоритет этого вопроса в том, что сегодня,
CHF
в
and
2020
diabetes
году,
mellitus
помимо
type 2.
инновационного
The
препарата
priority is
кубитрилсартан,
that
который
in
уже стал
2020,
активно применяться на протяжении
besides
последних лет,
cubitril/sartan,
появилась
which
группа
has
еще
been
два
used over the
ингибитора,
next
которые на
several
основании
years,
двух
there are
исследований
also
DAPA-HF и MPROGRADIENT доказали
SGLT2
свою принадлежность
inhibitors,
и свой эффект у больных
which
КСН. И, скорее
showed
всего,
their
эти вопросы
efficacy in
должны вставать
patients
всегда перед
with the
клиницистом. Как
CHF.
отдавать
I think
приоритет,
these
как комбинировать
questions
эти препараты у
should be
больных с
raised by
КСН и
the
диабетом.
clinician.
И я
How
передаю
to
слово Анне
combine
Ивановне.
these
Анна
drugs in
Ивановна.
patients with the CHF and diabetes.
Добрый
And
день,
the
глубоко
floor is yours.
уважаемые коллеги.
Well, good
Да,
afternoon,
очень
distinguished
актуальная
colleagues.
проблема,
Yes,
проблема
this problem
ведения
is very
пациентов с
relative.
сердечной
Management of
недостаточностью,
patients
сахарным
with the
диабетом
CHF
второго
and
типа.
diabetes mellitus type
Действительно,
2. And
сердечная
indeed,
недостаточность, сахарный диабет –
heart
два
failure and
заболевания,
diabetes
взаимно
mellitus are
влияющие друг
two
на друга.
diseases
По данным
impacting one
фрамингенского
another.
исследования,
According to
сахарный
Framingham
диабет
study,
ассоциирован
diabetes
с
mellitus is
увеличением риска
associated
развития
with
сердечной
the twofold
недостаточности у мужчин в
increase
2 раза,
of
среди женщин в
CHF
5 раз.
in men and
Распространенность сердечной
5
недостаточности
times
среди
in
пациентов с
female.
сахарным
As
диабетом
for
второго типа
the patients
составляет
with
12% и
CHF,
более по данным разных
12%
исследований.
of them
Распространенность
have diabetes
сахарного
mellitus
диабета
and
среди
vice
пациентов с
versa.
сердечной
Diabetes
недостаточностью
mellitus among
колеблется
patients
от
with
25
CHF
до
accounts for
50%.
25 to
Как мы знаем,
50%. As
распространенность
we know,
сердечной
the
недостаточности
prevalence of
увеличивается в
CHF
связи с
increases
увеличением
with
возраста. Но у
age,
пациентов с
but
сахарным
patients
диабетом
with
еще в
diabetes
большей степени
mellitus
увеличивается
have even a
распространенность
higher prevalence
сердечной
rate
недостаточности
of
у лиц
heart
пожилого
failure,
и
especially
старческого
in
возраста.
patients
Интересные данные
of the
Шведского
elderly
национального
age. The
регистра
data of the
сердечной
Swedish National
недостаточности. В
Registry
этот
of
регистр
heart
включено
failure
более 270 тысяч
is of
пациентов с
great
сахарным
interest for us.
диабетом второго типа.
271,000
И
patients with
интересен
diabetes
анализ
mellitus of type 2.
влияния
Analysis
факторов
done
риска
showed the
на
impact of
частоту
risk
развития
factors on the
сердечно-сосудистых
frequency
заболеваний.
of
И
heart
оценивалось
or
влияние этих
cardiovascular
5
events.
факторов риска, как
They
гликированный
assessed such
гемоглобин,
risk factors
холестерин
as
гипопротеида, низкой плотности, систолическое артериальное
HbA1c,
давление, курение и
low
альбуминурия. И вот
density
если контролировать
lipoproteins,
эти 5
smoking,
факторов риска,
albuminuria. If we
то
control these five risk
вероятность
factors,
развития
the
инфаркта
probability of the
миокарда
development of
уменьшается на
myocardial infarction
16%.
is reduced by
Риск
60%. The
инсульта,
risk of
тенденция к риску
stroke
развития инсульта снижается,
is
но несмотря на
lower,
контроль
but
этих
despite the
важнейших 5
control
факторов риска,
of these five
риск
risk
развития
factors,
сердечной
the risk of
недостаточности
development of
увеличивается на
heart failure
45% у
increases
больных с
by
сахарным диабетом.
45% in
По
patients
данным
with diabetes
Международного
mellitus.
регистра ВИЧ,
According
у
to the
больных с сахарным
International
диабетом второго типа
Register REACH,
при
patients
наличии
with diabetes
сердечной
mellitus type 2,
недостаточности
when they
их
have
сердечно-сосудистая
CHF,
смертность
the
увеличивается в
risk of
2,5
cardiovascular
раза.
death
Риск
is
госпитализации
2.5 times
из-за
higher. The
сердечной
risk of hospitalization
недостаточности
due to
почти в 5
CHF
раз. У
increases almost
пациентов с
5
сахарным
times.
диабетом
Patients with
при наличии
diabetes
сердечной
mellitus, in
недостаточности
case of
существенно снижается
CHF, there
выживаемость
is a
уже в
significant
течение
reduction
первого
in the
года.
overall survival
Смертность
during the
составляет
first year. The
50%
death
по
rate
данным
is
этого
50%
исследования,
according to
а через
the
3 года
study,
смертность
and
составляет
after 3 years, the
80%.
mortality
Такое
rate is
влияние
80%. So
сердечной
that's the impact
недостаточности
of
на
heart
прогноз
failure
больных с
on
сахарным
the
диабетом. С
prognosis
другой
of
стороны,
patients
анализ
with diabetes
исследования
mellitus. On the other
ЧАРМ
hand,
позволяет судить
CHARM
о встречаемости нарушений углеводного
study
обмена
showed that
пациентов с
there is
сердечной
the
недостаточностью. Итак, в
poor
этом исследовании у
carbo
пациентов с сердечной недостаточностью
exchange
низкой
in
фракции
patients.
КТ и
In this
сохраненной
study,
фракции
there was
КТ
the low
частота
ejection fraction,
встречаемости
preserved ejection
сахарного
fraction,
диабета
and the
достигает
frequency of diabetes mellitus can be
61%
61 and 62%.
62% это
And
пациенты с
22% are patients with pre-diabetes. Only 16 and 80% of patients with CHF had normal glycemic profile. Patients with heart failure and reduced ejection fraction in case of diabetes mellitus have the worst prognosis. Overall survival is higher, sudden death is higher, as well as a higher rate of death from heart failure. The survival rate of patients with heart failure is worse in case of diabetes mellitus, regardless of the left ventricle ejection fraction. It is much less in patients with concomitant diabetes mellitus. In case of the preserved ejection fraction, it is even higher. In case of diabetes mellitus, the survival rate is much worse if there is reduced left ventricle reduced left ventricle ejection fraction. The diabetes mellitus is one of the major reasons for worsening of heart failure and one of the main reasons for hospitalization. Diabetes mellitus and heart failure are two aggravating conditions. Let me show you a clinical case. A patient, 68 years of age, coronary heart disease, also angina, post infarction, cardiosclerosis, well, hypertension during 15 years, well, also CHF2A, third functional class, the worsening of symptoms during the last month, such as shortness of breath, edema on the lower extremities during the last 10 years, diabetes mellitus type 2, diabetic nephropathy, well, CKD, stage C3A, albuminuria 2S. For the results of the examination, you can see the key indicators such as heart rate 130, blood pressure 130 over 75, the heart rate 64 beats per minute. You can see that there is a compensation of the carbo exchange, well, GFR 58 milliliters per minute. You can see low density lipoproteins and high density lipoproteins 2.8 and 0.9. Well, the patient was put on ramipril, bisoprolol, and eplerenone. These are the major drugs to treat heart failure. Toracimid, rosuvastatin, together with aspirin and dapagliflozin in combination with metformin, allowing us to achieve compensation of hydrocarbon exchange. What can we change in the therapy of the patient who have high compliance to treatment based on the Russian recommendations of 2020? We can say that in such situations, when there is no efficacy of Sartan inhibitors, we can administer Euperia. Euperia should be administered to reduce the risk of hospitalization due to heart failure and to avoid the patient's death. So here is the patient's decision to cancel ramipril 36 hours after the cancellation of ramipril. Euperia should be administered, then to continue therapy to increase the dose of statins to correct the lipid exchange. So in what dose? The patient was already on the ACI inhibitor in the therapeutic doses, so we can administer Imperia 100 milligrams twice a day. What are the arguments in favor of this therapy paradigm? HF study has demonstrated the poor hydrocarbon metabolism. 48% of patients had diabetes mellitus in this study, and 13% had diabetes mellitus diagnosed for the first time, and normal glycemia occurred only in 27% of patients. At the same time, the risk of cardiovascular death and hospitalization due to the progression of heart failure was the highest in those patients who had a history of diabetes mellitus. the risk of development of such patients with undiagnosed diabetes mellitus is lower, although it was still higher as compared to patients with pre-diabetes, and especially as compared to the frequency of events with normal glycemia. Thus, the Paradigm HF study showed that more than one-third of patients had diabetes mellitus, and in 13% of patients that was newly detected diabetes mellitus. The results obtained in the Paradigm HF study were applicable to patients with diabetes mellitus. When the Euparia was administered to patients with diabetes mellitus, there was a reduction of death by 20%, a sudden death by 20%, and a reduction of overall mortality. And as for this clinical case, as well as other patients with progression of heart failure, it is important that the curves depart quite early. You can see the difference in treatment role. Sartans, Cubitril was quite efficient. This combination can be compared to the standard of treatment such as AACI inhibitors, and of course, in this case, there were very positive results in the patient's condition. So there was a reduction of the progression of heart failure 30 days after the intake of the drug. Combinations such as valsartan, sacubitril, and again, you can see the indicator is 40%. Patients with diabetes mellitus have already shown the results proving that they have a lower level of glycated hemoglobin as compared to patients on enalapril and patients with diabetes mellitus. It is very important also during the sub-analysis and Paradigm HF study showed that Euparia leads to the leads to switching over to insulin in 29% of cases, less as compared to those patients who were on enalapril. Is it important? Of course it is, especially bringing to bear the mechanism of the negative impact of insulin on liver and on heart deficiency. Insulin holds down sodium, holds down liquids in the organism. That means a congestion, hypoglycemia, which often develops due to insulin therapy, leads to the activation of the sympathetic system, that is the tachycardia, myocardial problems. It has a negative impact on the cardiovascular system. Insulin can worsen the contractility of myocardium. That is why we should initiate this kind of therapy for such patients. The studies have shown that switching over to insulin in patients with CHF and diabetes mellitus increases the frequency rate of death and hospitalization due to heart failure. Our patient has a CKD stage 3A, albuminuria 2, and what is important is the results of a Paradigm HF, which in sub-analysis showed that patients without diabetes mellitus and patients with diabetes mellitus, due to the use of Euparia as compared to the use of enalapril, had higher rates of glomerular filtration rate. Euparia can slow down the progression in CKD. And of course, as we select the drug, we should take into account the functional condition of the kidneys, whether we basically need the correction of the dose. If GFR is 58, in this case, there is no need to do it. What else is important to slow down the progression of heart failure in patients with diabetes mellitus? The leading role in progression belongs to the process of remodulation, which have just been covered by Professor Arutyanov. The regress of remodeling is accompanied not just by improving the symptoms of the quality of life, it also the way to reduce the risk of hospitalization and death of patients with heart failure. The improvement of prognosis of such patients is usually linked to reverse remodeling, and the trials conducted have shown that when the conductivity of myocardium is getting worse, when the ejection fraction, left ejection fraction increases, the risk decreases the risk of heart failure, and the risk of death due to heart failure increases. Well, and the systolic and diastolic volume, if they are increased, there will be a higher risk of hospitalization as well as death of patients with heart failure. And once again, here it's important to assess the systolic dysfunction. As we know, the lower left ventricle ejection rate, growing systolic dysfunction leads to a higher risk of overall mortality. Dear colleagues, due to the importance of the impact on remodulation, it is important to have more knowledge about EUPERIA, how it impacts on remodeling. And in real clinical practice, it was demonstrated that 3 months after the administration of EUPERIA, the ejection fraction increases by 5%. So you can see that 7 in 10 patients have now a better function of the left ventricle. After a year of therapy, the ejection fraction of the left ventricle increases by 10% from 27 to 37, which is a wonderful result in terms of improving the functional capability of the myocardium. Moreover, it was shown that the higher dose of EUPERIA is used, the more there are the possibilities of impacting on remodeling, and the higher the regress is in case we want to make a prognosis for patients with heart failure. As you can see it here, when 400 milligrams per day is the dose of EUPERIA. In this case, there are a lot of capabilities to reduce the contractility of myocardium. Grigory Pavlovich, in his presentation, has already mentioned this, and I'd like to draw your attention to the proof HF study are concerned. That's a multi-center study. In open study, patients with heart failure usually have low ejection fraction, and we've shown the correlation of NT-proB and T with other structural data such as EKG, like the left ventricle, and it was shown that EUPERIA after 6 and 12 days significantly increased the ejection fraction of the left ventricle, on average by 9%, but in 25% of cases by 13%, which is a very good result. And it was also shown that there were improvement of the end diastolic volume. So EUPERIA improves the structure of different parameters. One of the major indicators that we must assess in patients with heart failure is the impact of therapy on the quality of life. And due to the use of EUPERIA, well, it was demonstrated how there is a significant improvement of the quality of life in patients with heart failure. There is a comparison group, patients on the traditional effective therapy for heart failure according to modern guidelines, such as ACR inhibitors and enalapril. The replacement of enalapril for EUPERIA led to the improvement of the quality of life, similar to the effect of resynchronizing therapy. Our patient, 3 months after this, well, was on Euperia, 200 milligrams twice a day, no titration period. All drugs were administered to her to treat heart failure and diabetes mellitus, dapagliflozin plus metformin, and you can see pressure is 130/70, heart rate 62. Well, the improvement of the condition, no edema. Well, the patient is more tolerant of physical exercises. Left ventricular ejection fraction improved from 36 to 41%. So, dear colleagues, CHF and diabetes mellitus type 2. I think that this is the category of patients with cardiovascular diseases who need this particular approach so that valsartan, sacubitril, Euperia could be included in the regimen. This will improve the protective abilities of system, including beta blockers, including SGLT2 inhibitors. In this case, you have a better treatment of patients with CHF and diabetes mellitus type 2. And as this study has shown the indirect comparison of 3 studies, this 4-component therapy, unlike ACI inhibitors or beta blockers, can allow us to achieve the good impact on the prognosis of heart failure, especially when the reduction of cardiovascular death by 60% and hospitalization, well, cardiovascular death by 50%, the hospitalization by 68%, and death from all causes by 58%. Plus, we can get 8.3 additional years of no death, no cardiac death. So for patients with diabetes mellitus, the use of Euperia allows us to obtain additional pleiotropic metabolic effects important for such category of patients. Well, sugar reducing drugs, SGLT2 inhibitors have an impact on the prognosis. Thank you very much. And thank you very much for your presentation. We have almost no time. We're slightly lagging behind. Let's move on to the next presenter, Sergei Terещенко, decompensation of heart failure. Sergei Terещенko is a leading expert in the field of acute decompensation of circulation patients with CHF. And within this symposium, our goal is to understand what patient, especially in the condition of decompensation, what should be the tactic of management of such people. There are lots of questions. Should we continue beta blockers or cancel them, or infusion of diuretics or something like that? Also pleural cavities, the initiation of additional therapy. If yes, at what stage it should be initiated? At what stage we should add complex drugs? We should have a clear algorithm of action in this situation. If we do not have this algorithm, if we start valsartan, sacubitril at different stages, we can get to different results. For that, there should be clear criteria as in transition. The category of patients that should be discussed as the critical aspects we should be talking about. And I don't want to go into details, but I should say that after Professor Terещенko speaks, there will be the session of questions and answers. These will be critical questions, sacubitril, valsartan, how to switch over to this combination. There will be a discussion among experts, and I hope there will be heated debates, just like in the rapid session when experts disagreed with one another. But in any case, we must understand that this symposium cannot just answer the question of CHF decompensation. That's a very wide topic. We can speak volumes on that. Nevertheless, just a few words before Sergey starts his presentation. What's the essence of the problem of decompensation? When the patient comes to the clinic, well, the patient has edema, well, low extremity edemas. You press on the skin and there is a force, and we must have a clear understanding that when the patient is hospitalized, that means a negative prognosis for the patient. Decompensation started working not today, not yesterday, but about a month ago. We must have a clear understanding of the sequence of events in the organism. First, retention of liquid. Maybe the patient is no longer on drugs. Maybe the patient has infection. He was not vaccinated, and there was decompensation. The person doesn't weigh himself. There is retention of liquid in the interstitial part, pneumothorax. The patient goes to the inpatient clinic. Well, the proper administration of drugs can prevent it. Sergey, now the floor is yours. The patient with the decompensation. Please, Sergey Nikolaevich. Well, can you see my slides? Yes, everything is okay. Well, thank you very much. So I'm talking about decompensation of ADHF, acute decompensated heart failure. I'd like to thank Professor Artyunov for inviting me to speak at the symposium of the Eurasian Association of Therapists. Thank you very much. So the theme of my presentation is ADHF, once again, acute decompensated heart failure. Of course, the heart suffers most after this chronic heart failure develops. Well, you can see the new Russian guidelines that have already been mentioned today. In these recommendations, there is the section on ADHF. What is our goal? Yes, we must improve a prognosis, but for our patient, the most important thing is to improve clinical symptoms so that our patient could feel himself healthy, so that he could do the standard work done before the disease, and also to reduce the number of hospitalizations. ADHF occurs in 5.5 million cases in Russia every year. The patient is hospitalized for ADHF, and the patient has edema. The patient has the heart function worsened, especially the left ventricle. The pump doesn't work properly. The patient has the major problems developed, mentioned by Professor Artyunov, and Anna mentioned about this. Remodeling takes place, and target organs have been affected. The patient will be hospitalized again within a 30-day period after the discharge. The 30-day mortality is 22% in case of ADHF. Just think about this figure. 22% is the 30-day mortality from ADHF. It's higher than in case of acute MI. What is happening in case of decompensation? First of all, target organs suffer, such as acute kidney damage, acute or renal syndrome, also the negative process of remodeling, the risk of development of arrhythmia, and again, the liver suffers as well as the central nervous system. What markers do we use to assess the target organs? Well, NT-proBNP has already been mentioned. We use NT-proBNP not just in treatment, but also for assessing the poor outcomes. Elevated NT-proBNP is associated with a higher risk of death. Troponin should be checked in case of cardiomyocytes damage. Cardiomyocytes damage leads to elevated troponin, hence a higher risk of death and or repeat hospitalization. ACT and AST and LAT, usually have elevated levels in about 50% of patients with ADHF. This biomarker is associated with a higher risk of death. Creatinine level is elevated. GFR is dropped. This leads to negative consequences in case of acute decompensated heart failure. It's a vicious circle from the chronic heart failure, unfortunately, to tragic outcomes. And again, you can see here that the kidney function is affected in case of ADHF, and it's a negative remodeling process. It's the progression of heart failure and an increase in the number of hospitalizations. Each hospitalization brings the patient closer to the tragic outcome. The more hospitalizations the patient have during the year, the worse is the outcome in such patients. After 4 hospitalizations, the median overall survival is just a half a year. In patients with ADHF, we can assess the efficacy of a particular drug using the time scale of 180 days. Within this period, there is an improvement of the prognosis. In this case, we can talk about the efficacy of drugs. And I'd like to say that chronic heart failure is an orphan, so to say, among different drugs that can be applicable to it. The treatment of ADHF cannot be done by using new drugs that could improve the prognosis for patients with patients with CHF. Well, recombinant natriuretic peptide or a peripheral vasodilator, so diuretics, unfortunately do not improve the prognosis in patients with chronic heart failure. And of course, we have to use drugs like oral drugs to reduce the number of hospitalizations in this case. So what are the reasons for acute decompensation? There are trigger factors that can be different. It can be infection, and right now this is very relevant, bringing to bear the COVID-19 pandemic, but that's not an eye-opener for us. When we're talking about patients with chronic heart failure, obviously there may be decompensation. This has been shown in other works. Common cold and the flu also leads to a higher rate of hospitalization of patients with ADHF. Well, let me just first say a few words about the wrong therapy. When people have a lot of salt and liquid in their food. Well, unfortunately, patients after their discharge do not come to the catchment area. Doctor to a family physician 2 weeks later, as it should be done. And often doctors do not know what the patients are doing. Usually when patients are discharged, well, they get the minimum dose of a drug that the doctor thinks the patient is being treated, but that is not so. And we know that the efficacy for drugs has been proven only when they are administered in maximum dose. Beta blockers, valsartan, and SGLT2 inhibitors showed that the maximum efficacy only in higher doses. The goal of treatment is that patients with ADHF should have better hemodynamics, have oxygenation restored, and as soon as possible to administer per oral drug if it had been canceled before. Here you can see the Russian guidelines, clinical guidance on the use of oral anticoagulants. Patients with acute decompensation with the reduced ejection fraction, in order to improve the clinical outcome, we should start the treatment that has a favorable effect. Well, these are very well-known drugs, beta blockers, mineralocorticoid receptor agonists, and sacubitril and sartan. Patients with acute decompensation in case of low blood pressure, low conductivity, low heart rate should have the dose of beta blockers lowered, and parenteral treatment should be initiated in this case. Patients with systolic dysfunction and CHF, well, valsartan's sacubitril should be switched over. Well, on the basis of what can we come up with such recommendations? Well, on the basis of a Transition and Pioneer, these are two large-scale studies conducted on patients with acute decompensation of chronic heart failure. And again, you can see a Pioneer HF study, that's the number of hospitalizations due to acute decompensation with the ejection fraction, with the higher level of NT-proBNP after the situation was stabilized. After the hospitalization, you can see the blood pressure is 100 millimeters mercury. Well, there were no diuretics administered to this patient, and in this case, the patient got sacubitril valsartan in therapy. Thus, a number of patients included in this study showing that more than 70% of patients are patients with functional class 3 and 4, very severe patients. And please see here, that's the primary endpoint, the death, the hospitalization due to heart failure, or the need to reimplant the left ventricle assist device. So this is an interesting study. There was the comparison with angiotensin converting enzyme comparison. I should say that this is the only multi-center study, Paradigm and Pioneer HF, where the two drugs are compared. One is the golden standard, another is a new drug. Everything is compared with placebo in order to determine efficacy, but due to ethical considerations, it was impossible to do the comparison with placebo. That is why angiotensin converting enzyme drug was used. So you can see angiotensin converting enzyme is compared with Uperia. And dear colleagues, you can see how fast there was the normalization of the clinical condition. The clinical conditions improved during the first day. I should say the curves departed and in favor of Euperia. Also, it is worth noting, dear colleagues, the number of repeat revascularization, implantation of fibrillator or other devices. It was basically the same in both groups, but the number of repeated hospitalizations. Here we can see that patients on Euperia, the number of hospitalizations was much less by 44%. Now, as for safety of Euperia, I should say that we are dealing here with a very severe group of patients. There were no worsening of kidneys, hypertension, as we usually expect in this situation when there is a double blocker. On the one hand, angiotensin converting system, and on the other hand, neprolizine has a vasodilating effect, and of course, we did not expect the hypothonia in these patients, especially due to this combination. So you can see that initiation of sacubitril valsartan can be considered more preferable for patients with decompensated CHF in order to reduce the risk of unfavorable events and for simple patient management. This is the European consensus of the European Society of Cardiologists. And in our recommendations, we have written into it that patients with CHF, if arterial pressure allows, we recommend to switch over patients from angiotensin converting enzyme to sacubitril valsartan instead of sartan inhibitors. Well, there is another drug, and this happens usually after the stabilization of the patient. The criteria of readiness: who should be discharged from the inpatient hospital? Patients who are hospitalized due to heart failure, they should be hemodynamically stable, and they should get oral therapy. They should have stable kidney function, and we should have enough materials on self-help. That's very important to our colleagues, because we must remember about the so-called seamless management of a patient with chronic heart failure. The risk of rehospitalization, and I have already mentioned it, has a negative impact on life prognosis. There is still high risk of neuroinstability, and I would like to say that repeat hospitalization is bad, but what is happening in real clinical practice? Unfortunately, the situation is very sad. You can see a large number of patients who, while on ambulatory treatment, stop taking the same drug. Drugs can be cancelled, drugs can be used, but with the caveat in a different dose. Sometimes patients ask questions, how long should I take in this drug? What should be the pulse scheme? We understand that, of course, you should continue this kind of therapy. The dose of drugs should be titrated to avoid the episodes such as decompensation of the heart failure, and also continuity between the inpatient hospitals. Well, you can see, dear colleagues, according to Professor Fomin, this change of regimen happens quite often. Up to 60% of cases will have their therapy changed. What can you get out of it? Look here, the death and their hospitalization. In a case of the better drugs, we can pay attention to this. As soon as we change a drug, unfortunately, will be the culprit because the prognosis among such patients will increase. As for the symptoms we see in our patients, that of course the result of the so-called remodeling of the heart, myocardial dilatation, and it's one of the prognostic indicators. So it is important for us to have an impact on the clinical condition of the patient, to reduce the symptoms, but also we must have an impact on remodeling. Grigory Pavlovich showed us how the cavities of the heart change in patients with CHF, and here the risk of MACE will increase in case of remodelation of heart. The more processes occur and they fall into active remodeling, the worse the prognosis for life of our patients. This slide has already been shown here. My colleagues were talking about vessels and filtration, and of course, the issue of remodelation should not stand aside because the most effect of remodeling is on myocardium. In this case, myocardium can be affected. The lower the ejection fraction, the better the left ventricle fraction. This can increase the diastolic size of left ventricle by 10 millimeters. In this case, there will be a higher risk of hospitalization, a higher risk of death by 9%. And when the systolic approach volume is used, in this case, we can reduce the risk of hospitalization by 15%. This is a very important slide, dear colleagues. Please pay attention to the fact that 3 months after treatment by Euperia, more than 7 out of 10 patients had an increase in the ejection fraction. And you can see in a year there is a significant increase in patients with the higher left ventricle ejection fraction. Well, proof-HF was already shown many times. These are the recent data. You can see how reverse remodeling takes place when Imperial is used on patients with chronic heart failure. In 25% of patients, there was an increase of the ejection fraction by 13% during the first 12 months. Not a single drug can achieve this effect. Frankly speaking, I haven't seen such an effect on beta adrenal blockers. This slide is very important. Of course, you should use the maximum dose. And in conclusion, dear colleagues, I'd like to say that we need to organize a specialized care for patients with chronic heart failure. This seamless care will mean better compliance, reduction of the risk of repeat hospitalization, and a drop in the mortality rate after the discharge. Thank you so much again. It was a pleasure to speak at your symposium. Thank you very much. Unfortunately, we are behind the schedule. We just were given 30 seconds. That's it. Sergey, the key question for you. Say just yes or no. Can you recommend Euperia for patients who are in the hospital due to decompensation? Yes. Anna, what is your question, yes or no? Do you believe that the management of patients with diabetes mellitus today should be expanded and should not be just drugs normalizing the glycemic profile be administered? Can I ask a question? Well, as a chess master to chess master, Grigory, well, what is your view? ACE inhibitors, is their era gone? I think so. Yeah, their era, their century is gone. Well, ACE inhibitors were important, but this era is gone. ARNI will be used right now, and Uperia is one of them. Thank you very much for your participation. Thank you, dear experts, for these interesting presentations. There will be a break right now. After the break, that will last until 15:45, there will be 3 more symposia in the Moscow hall. There will be a symposium devoted to COVID-19, but not in terms of internal organs damage, but in terms of therapy, anticoagulation therapy, anti-inflammatory strategy, JAK kinase inhibitors, clinical pharmacologist position, and of course, rehabilitation after the COVID-19 infection. In St. Petersburg, we're going to have a symposium devoted to relevant questions of GI pathology in cardiac patients. They will raise important questions, anticoagulants, administration, patients with ulcer, PI in proton pump inhibitors, and in term we'll be discussing nephrology issues. And I'd like to draw your attention to this symposium because chronic kidney disease is an integral part of any pathology, and of course GFR should be assessed not only in terms of the dose selection, but also in terms of treatment tactics. A 10-minute break. Thank you so much.
Вести активный образ жизни, делать то, что хочется. Как редко мы задумываемся о ценности здоровья. За видимым благополучием мы не сразу замечаем серьезных изменений. Пациенты с хронической сердечной недостаточностью попадают в водоворот дом, поликлиника, стационар. В ваших силах вовремя предложить им помощь. Какова цена промедления? Снижение фракции выброса ниже 50% даже на начальных этапах развития систолической дисфункции говорит о развитии процессов ремоделирования миокарда. Причиной этого является нейрогормональный дисбаланс. Увеличиваются камеры сердца и снижается фракция выброса. Эти изменения приводят к снижению перфузии всего организма. В миокарде усиливаются процессы фиброзирования, увеличивается доля соединительной ткани, приводя к формированию очагов электрической нестабильности и повышению риска внезапной смерти. Камеры сердца увеличиваются, сердечная мышца теряет эластичность. Процессы фиброзирования миокарда и ремоделирования сердца протекают у каждого пациента с хронической сердечной недостаточностью и систолической дисфункцией, даже на ранних стадиях. Согласно данным исследования, пациенты второго функционального класса также находятся в группе повышенного риска внезапной сердечной смерти. 5-летний прогноз выживаемости пациентов с хронической сердечной недостаточностью сопоставим с таковым у многих онкологических пациентов. Поэтому при выявлении систолической дисфункции, когда фракция выброса снижается менее 50%, следует без промедления задуматься об оптимизации терапии. Сегодня есть возможность повернуть вспять процессы ремоделирования на ранних этапах развития систолической дисфункции, что может помочь обеспечить более долгую и качественную жизнь пациентам и дать возможность защиты от риска внезапной сердечной смерти. В исследованиях было показано, что применение современной терапии позволяет значительно снизить процессы фиброзирования миокарда. Обратите внимание, как снижается показание маркера фиброзирования SST2. В исследовании Proof-HF показана возможность повышения фракции выброса почти на 10% в течение года терапии с акубитрилом валсартаном. Исследование Paradigma HF, в котором 70% пациентов были второго функционального класса, удивила весь профессиональный мир, показав значительное снижение риска внезапной смерти на фоне современной терапии. Любой пациент с фракцией выброса менее 50 может получать современную терапию, дающую возможность защиты от прогрессирования заболевания и рисков внезапной смерти.
Уважаемые коллеги, добрый день. Мы продолжаем нашу конференцию. Мы подошли к завершающей сетке симпозиумов. Я напомню, что в этом симпозиуме будет проходить целый симпозиум и серия докладов, посвященных COVID-19 в зале Санкт-Петербург. Общие вопросы гастроэнтерологии и, наконец, в зале Пермь вопросы нефрологии в повседневной практике. Каждый может выбрать зал, который ему будет интересно. Я хочу остановиться на зале Москва, потому что COVID-19 красной строчкой проходит через всю эту конференцию. Мы не имеем права сегодня на фоне измененной медицины отбросить тему COVID-19 и не говорить о ней. В ходе сессии «Вопрос-ответ» я получил более 40 вопросов, посвященных COVID-19. На некоторые я не успел ответить, но я очень надеюсь, что ответы на них прозвучат сейчас. Почему это так важно? Потому что там, где мы говорили о поражении органов мишеней, мы говорили, как ковид меняет организм. Здесь мы поговорим о вопросах лечения и вопросах реабилитации этих пациентов после перенесенной коронавирусной инфекции. Я попрошу всех спикеров соблюдать регламент, потому что мы ограничены по времени, у нас очень много докладов, но я хочу особо отметить и поблагодарить всех, кто работает и продолжает работать в красной зоне. Все спикеры, которые вы видите сегодня на докладе, на этом симпозиуме, все либо работали, либо продолжают работать и консультировать в красной зоне, то есть работают с коронавирусными пациентами, инфицированными SARS-CoV-2. Я позволю себе перейти к теме своего выступления. Я хочу затронуть две ключевые стратегии. Сейчас я попрошу вывести на экран мою презентацию. И я хочу затронуть две принципиальные стратегии ведения этого больного. На сегодняшний день COVID-19 получил, с моей точки зрения, два вектора. Антикоагулянтный вектор и вектор противовоспалительный. Если мы попытаемся представить, как развивается каскад болезни, когда человек инфицируется, то вирус проникает в ткань, начинает сцепляться с экзопептидазой АПФ2, это приводит к росту ангиотензина 7. Это приводит к неминуемым изменениям, которые красной демаркационной линией отделяют.
The inevitable changes that separate with the demarcation
вот этот воспалительный каскад
line.
начинает менять ситуацию. Этот воспалительный каскад
This inflammatory cascade is changing the situation, and we see a growing progressive dysfunction of endothelium. We see that the patient has a progressive synthesis of nitrogen oxide, and we see that this patient has a growth of amylin factors, and the second vector, thrombotic or coagulative vector, is ignited. Here we use low molecular heparin. Sometimes we use unfractioned heparin in specific cases, and we speak of using DOACs, but two vectors are connected in one line, inflammatory and coagulative cascade. I'll speak about this based on the data on the Russian population that we have. Let's start from anticoagulation strategy. The first question to mention is, what are we based upon when we assess the severity of the patient? Very often, we are based on CT and CRB data. Why? Because CT is done in 90% of the cases at least once on our patients. If we look at the entire Russian sampling, based on the active COV registry, we'll see the way the patients are distributed based on the CT scan. CT1, 3, 2, and 4. We understand that outpatient patients are easier in hospital, more severe, but the average sampling is like this. It's important to ask ourselves a question. Do you want to keep the DOAC for the patient with AF or non-AF? Why is it important to keep the DOAC no matter what previous anticoagulant the patient was receiving? But if we look at the glomerular infiltration speed of the patients above 30, no problem. As soon as we go down below 30 milli per meter, we have either rivaroxaban or apixaban or unfractioned heparin. and below 15, it's unfractioned heparin only. Why is it important? Because a large number of patients, especially resuscitation patients, will have acute renal dysfunction. And if the patient didn't have a substitutory renal therapy, we won't be able to give him this dose. If the patient has a low level of CT 1 or 2, and for AF he was getting DOAC, we can leave them. CT3 worsening, we always switch to low molecular heparin. What should the strategy look like? We ask a question. DOAC, CT degree, if CT is 3, we continue. If it's not 3, it's 1 and 2, we continue giving him DOAC. If his CT is 3, the patient has no atrial fibrillation, we give him low molecular heparin with SKF below 30. If the glomerular infiltration speed is above 30, then infusion is more preferable than bolus. Moreover, subcutaneous injection is not efficient. If there is active bleeding, we don't start this strategy, and our main focus is the possible use of sodium fludarabine. But this is optional and the decision should be made. Oral anticoagulants, fractioned, unfractioned heparin, will inevitably lead to the reduction of D-dimer. So can we say that this anticoagulant strategy will reduce the probability of inflammation and the cytokine storm? Unfortunately, we can't. We know that there will be no reduction of this kind. On the contrary, anticoagulants are given to more severe patients, and lighter patients do not get it. That's why we have a distortion. These patients have cytokine storm, while everybody needs anticoagulants in this situation. Cytokine storm has prerequisites, and we try to evaluate it in active cough registry. We saw that above 60 years old, there are no definitive prerequisites, but below 60, comorbidity is a reliable prerequisite for cytokine storm. The more concomitant diseases such as obesity, CKD, ischemic heart disease, hypertension, diabetes, etc., the higher the probability of cytokine storm is. Those below 60 years old, and here we need to keep in mind that a comorbid young patient always entails a higher risk. What about drugs? I don't want to go deep in this because the next presentation will be about rheumatological group of drugs, and maybe glucocorticosteroids will be talked about. I want to show you the data we have. First question, what about statins as anti-inflammatory drugs? Do they impact cytokine storm? No, but as for C-reactive protein, yes, they impact on it. We need to keep in mind that statins will be reducing this probability. Also keep in mind that intravenous injection of glucocorticosteroids, rheumatological drugs, especially glucocorticosteroids, is significantly stronger than the rheumatological group, reducing the level of C-reactive protein, and indirectly it prevents from the cytokine storm from happening. Myocarditis is not only an acute failure of myocardium that we observe in the patients. We need to keep in mind that if the cardiofemins are growing, the patient will have rhythm failure, and the patient has all the chances for coronary complications. And there are problems of cardiotoxicity. If we ask ourselves a question, do the statins reduce the probability of myocardium infarction? No, statins reduce the probability of cytokine storm, but as for myocarditis impact, they don't. Acute renal failure is also a manifestation of cytokine storm. If it is treated like that, let me remind you that up to 7% of all COVID patients will endure FEP. We also know that 5% will require the substitutory renal therapy. Will this lead to acute renal failure? No, not at all. We see a clear correlation. More severe group with more aggressive approach gets hormones, and these patients develop more frequently the acute renal failure. But let's read the statistics accurately. Not hormones and rheumatological drugs are increasing the chances for chronic renal failure, but more severe patients are getting this therapy. Therefore, they develop more often the renal failure. So we exclude we can't say we exclude hereby the probability of cytokine storm. Will this lead to the shortest in-hospital stay? No, these patients are more severe. They stay in hospital longer. Will this strategy lead to the reduction of D-dimer? Yes, it will. And we know very well with high degree of probability that, on the contrary, rheumatological group will definitely lead to D-dimer reduction more than glucocorticosteroids will. D-dimer is treated as a component. Tocilizumab is injected to these patients. In fact, it's not correct. Will it reduce the lethal outcome and heart-lung machine for the patient? No, because it often happens too late, and statistics shows that late injection will not save the patient. We need to understand that this injection should be done as soon as possible. If we use this strategy at early stages, not when the cerebral protein is 250, but before it begins to grow. We need to begin the anti-inflammatory strategy and not when it's too late. To conclude, I want to say that all the deceased patients had expressed inflammatory manifestations on C-reactive protein in D-dimer and expressed lymphopenia, high viral activity, and two strategies, coagulation. And as for anti-inflammatory strategy, I want to say the questions are open because we don't know, not everywhere we do this. We don't have the experiences of treating cytokine storm and lung failure. These questions will be taken at symposium, and interleukin-6 blockers, use of glucocorticosteroids are the topics that will be covered by our next speaker. I'd like to give the floor with great pleasure to Sergey Zырянов. He's a clinical pharmacist. He works in Red Zone. He has huge experience of managing these patients. We need to understand that if in coagulation we found consensus, but in anti-inflammatory strategy, we still have a lot of open issues. This will help to prevent cytokine storm because simply tolerated myocarditis will never be left without consequences. Thank you, Alexander Grigorovich. Hello, dear colleagues. The topic that I have to discuss now with you is a bit hard to interpret. No matter how sad it is, unfortunately, we don't know. We don't know much at the moment about the strategy of managing COVID-19. Unfortunately, we understand by now that COVID-19 is a virus that is virus regulates the inflammatory process. We get the proning to clotting we understand that interferon synthesis is inhibited, hyperreactive inborn immunity suffers, and cytokine release syndrome is activated, the so-called cytokine storm. This is what we understand. Based on the today's idea on pathogenesis, it may seem that the impact on some pathogenetic chains is quite understandable, and probably it would be very attractive to impact JAKs, the Janus kinase. With the participation of JAK, as we know, the natural killers are activated and they play a significant role in cytokine storm. The knowledge on hyperactivity and the increase of interleukin content and activity simply require to use anti-IL-6 activity drugs. In terms of pathogenesis, everything is clear. What about practice? The true practice, colleagues, in fact, is not so much confirming our scientific findings. Of course, all those scientific hypotheses that were raised, they were researched, and all the molecules that could make an impact, they were either researched or they have been researched or are being researched in the clinical studies. The first group of drugs where I want to leave my comments on, these are Janus kinase inhibitors, babocetinib and opacetinib. Baricitinib, we have only one completed study there. 12 patients have been enrolled in it. Colleagues, please note it. This is the population that was researched. The drug in question was lopinavir, ritonavir, and neither randomization nor the sequence of administering was considered. On 12 patients, baricitinib showed some efficacy, but the effect was not so proliferated as we anticipated. Moreover, the efficacy in what concerns the primary endpoints was not studied. At the moment, there's an enrollment in a large study on efficiency of the cough barrier is conducted. But until now, all these enrollments haven't been completed. Moreover, there's a series of works that is planned on the evaluation of the efficiency of Baricetin. As of today, we don't have the reliable clinical data on using breath. That's why it cannot be absolutely recommended to the entire population of patients. We may consider the use of this drug as an additional therapy, which, as it was fairly mentioned, should be done during when the patient has unfavorable outcome forecast, above 50, concomitant diseases, and as for tofacitinib, we don't have even this level of confidence, and the assumptions that we had are not confirming this at all, because a clinical study that was completed pre-term was in fact very disappointing, because the results that were generating didn't confirm this hypothesis. Nevertheless, a number of scientific programs is being planned, and at the moment they are being developed, and we will probably get a more detailed idea and on the use of tofacitinib in the treatment of COVID-19. Today, we have no evidence yet. As for tocilizumab, it's an interleukin-6 inhibitor. Of course, it's a very attractive group of drugs, because we know the hyperactivity of this cytokine is accompanied with the expressed unfavorable events that happened in the end of the life of COVID-19 patient. And this drug is the most studied, I have to say, out of all the drugs. And we recently studied this matter. We found 43 projects that study the safety and efficacy of tofilizumab, but only 4 of them have been completed. And colleagues, I have to say that unfortunately the results of the completed studies are not promising at all, because 3 projects were interrupted preterm because it was not possible to prove the efficacy of tofilizumab in comparison with other inflammatory drugs. And of course, it hasn't been shown that tofilizumab has advantages. Only today, in broad, tofilizumab was indicated to the COVID-19 patients with moderate and severe course of disease. The use of these drugs not in the end of the disease, not during the cytokine storm, but earlier, as at the onset. Our colleagues tried to do this. 234 patients were very well randomized, blind randomization. They were divided into 2 groups, those who got, those who didn't get the drug. And unfortunately, and I don't think we should comment on a lot of these, you can see the survival curve, and you can see the need of oxygen support and the curves of clinical worsening and improvement. In 2 groups, we don't have much of a discrepancy, and the efficacy is almost the same for these 2 drugs. Tocilizumab, as of today, is still being researched, and it still takes its special place in clinical guidelines, including the clinical guidelines of a number of regulatory agencies. It was included in the recommendations of the Ministry of Healthcare version dated to the 1st of October this year. As for sarilumab, unfortunately, the situation is desperate here, because the manufacturer of this drug completed preterm the double-blinded, placebo-controlled study, because it didn't reach either the primary endpoint nor the secondary endpoint. And as of today, sarilumab is not researched anymore by the manufacturer. Can we draw some conclusions? Unfortunately, it's too premature to draw conclusions, I'm afraid. Of course, JAK inhibitors and anti-IL-6 drugs should be studied additionally, and only a more detailed, a more thorough study of all properties of these drugs will help us to draw final conclusions. Alexander Grigorievich. Sergei Kinsarimovich, thank you very much for your presentation. When we reach Q&A session, I will ask you to comment on one more drug that was actively being deployed as for anti-inflammation. It's levilimab. It's actively being used. I'm curious about your opinion about it, and I fully agree with you. We need extra research, and I have to say that we have no chance not to use these drugs, because very often they are used not simply as a therapy of despair, but a need to help the patients. Our centers have been using this drug a lot, and you're right, sometimes we see the patients with CRP 0, but there's certainly a positive dynamics. Although I can't argue with the randomized studies, from the perspective of private personal experience, we believe that there is a hope for the improved forecast for these patients. I give the floor with great respect to Maria Viktorovna. She's a pulmonologist working in the red zone. She'll share her experience of working in red zone, not only the pulmonary affection, but also matters of rehabilitation of these patients, because sometimes they stay in hospital for weeks and they can't deal without oxygen support. The floor is yours, Maria Viktorovna. Sound, please.
Сейчас слышно?
Can you hear me now?
Спасибо
Yes.
большое. Прошу прощения. Я все-таки немного повторюсь еще раз.
I do
Хотя
apologize
уже
for the
говорила
inconvenience.
о поражении органов дыхания. И на
I was
сегодняшний
talking
день,
about
когда
the
мы все уже знаем, что вирус, прошу прощения, вирус проникает в клетку с помощью рецептора
about lungs, we know that virus penetrates into the cell through a receptor, and the cells that contain this receptor in abundance, these cells are located in lungs, in alveolocytes, and of course the virus first destroys the upper tract, and then it goes to the pulmonary tissue. We see the lung destruction, we call it viral pneumonia, viral destruction, when there's a cascade of inflammatory reactions. The virus damages the cells, it causes cytokine storm, other cells that participate in inflammatory process, T lymphocytes, monocytes, macrophages, and this pro-inflammatory loop is closed, and we see not only a viral affection, but also the affection of pulmonary tissue, because a lot of cytokines and chemokines have been produced. If the person has a healthy immune response, then the situation doesn't go so far, he is healed. While if there's a defect, if the immune response is defective, or this person experiences extra viral load, then the immune cells are accumulated in the cells. There's a hyperproduction of pro-inflammatory cytokines. The pulmonary tissue is destroyed, and acute respiratory syndrome develops. Yes, we know that patients may have poly-organ failure. The virus may penetrate in other organs and affect them, because there are receptors there too, and these cells can be affected too. Besides, systemic inflammation may develop, and we eventually have poly-organ failure of the patients with COVID-19. So rehabilitation should concern not only the respiratory organs, but restoration of other organs and systems. If we look at the lung transformations, we'll see on the macro imaging, the lungs are dense, airless, with a lot of hemorrhagic infarctions and clots in the branches of pulmonary arteries and in the veins. On micro histological study of the material, you can see the diffusory alveolar failure in lungs. Both phases can be the exudative and proliferative phases, and along with that, there will be an intra-alveolar edema. And another typical thing for COVID-19 is alveolar hemorrhagic syndrome. And as Alexander Grigorovich said, in lungs, we see both cascades, coagulation and inflammation. And proliferative phase, in proliferative phase, we have activity of fibroblasts manifested and fibroplastic processes in lung tissue. The changes we see on the CT, thoracic CT, are known. We see multiple densifications of the lung tissue, like matte gloss. It is typical for alveolar edema. We can see the areas of lung tissue consolidation, and also Rocky Road syndrome. These syndromes are subpleural, peribronchial, and supraparietal. And a number of patients, as we know, apart from viral pneumonia signs at different stage, at exudative or proliferative, they may manifest also bacterial and fungi pneumonia. And if we take a look at the patients who tolerated coronavirus infection, for a long time they have persistent symptoms of the disease. One of the studies shows that on day 60, the patients were analyzed. Over 55% of the patients had 2 or 3 symptoms persistent: fatigue, shortness of breath, pain in joints, pain in chest, and of course cough. It's a severe infection, a complicated one, and of course these patients need rehabilitation, and we know that rehabilitation is a complex of measures aiming at the restoration of functions and considering the large scale of polyorgan failure, not only lungs, the approaches to rehabilitation should include restoration of pulmonary function, normalization of cardiovascular work, gastrointestinal, renal functions, restoration of cognitive functions, and increase of the entire robustness, physical robustness, and overcoming the stress and depression in the patients. Our mission in rehabilitation is short-term, when we need to begin it in our hospitals, when the mission is to stabilize the disease, to ensure the control over the symptoms, restoration of optimal physical and psychological shape. It is necessary so that the patient can go back to his normal life. And long-term tasks is something we challenge ourselves with. Identification of risk factors, elimination, and most importantly, prevention of not so much acute but chronic diseases that are getting destabilized or are acquired by the patients with coronavirus infection. If we look at the principles to follow, the following becomes clear. Well, first of all, we need to evaluate indications and counterindications and to evaluate the rehabilitation potential of our patients. In rehabilitation, a tailor-made approach is important. And the regime and intensity of rehabilitation should be tailor-made too. We should start early rehabilitation after stabilizing the patient clinically. We need to have a gradual increase of load, and it should be strictly dosed and have stage-by-stage principle. We have clinical guidelines that are dedicated to the rehabilitation of the patients with COVID-19 infection. They highlight 3 steps of rehabilitation, and the first one should start in resuscitation unit or in therapeutic department. If we're talking about readmission, nutritive support, respiratory rehabilitation, postural correction, early immobilization of the patient's cyclic velokinesis already need to be conducted by the patient when their condition gets stable. At step 2, rehabilitation should be done in medical institutions. At the third part is the in-hospital stay that can be conducted at home or in the hospital, in the university by means of telemedicine. If we look at the methods suggested by the medical rehabilitation, we do have recommendations and we can always visit there, but in rehabilitation of the patients we must use and we should use breathing, physical exercises, some trainings with extra weight. We need to improve the tolerability of intense physical loads. Some patients may use nebulizer therapy, manual therapy, physiotherapeutic procedures, and of course measures for psychological correction. As for pulmonary rehabilitation, its mission is to improve the air ventilation, gas exchange. We need to reduce the symptoms and increase the quality of life of the patient and socially adapt them. Pulmonary rehabilitation, to a large extent, includes, first of all, sports, and WHO, together with a large number of countries. Our country was also taking part in developing these guidelines for the patients. This guideline is a methodological book for the patients to study. It describes instructions. What do we need to do to the patient if his condition gets worse? For example, shortness of breath. What kind of exercises do they need to do? What should they do in their own environment? If we look at the evidence of rehabilitation, it yields a result indeed. This is a study, 6-week pulmonary rehabilitation study, and we see that the patients that have covered a 6-week pulmonary rehabilitation have an improved function of palms. And the patients who underwent rehabilitation have best parameters of FEV, forced vital liquid. We see that the diffusion capacity of lungs are easier. The patients that didn't go to pulmonary rehabilitation, it's the blue line. During 6 weeks, it doesn't increase anymore, and the green line are the patients who had lung rehabilitation, and look at how significantly their diffusory capacity of lungs have been increased. And the last graph, a 6-minute test was evaluated. We see a control group, while those patients who underwent the 6-week pulmonary rehabilitation, with them we see that the parameters are really getting better on 6-minute test, and the tolerance of physical load is better tolerated on them. To conclude, as we speak about pulmonary failure, we know it's a viral one. It's typically diffusory alveolar destruction, often combined with alveolar hemorrhagic symptom. A number of patients may have, in addition, bacterial pneumonia, and of course, holistic medical rehabilitation is a must for these patients, not only for lungs, but also a relevant approach for other organs and systems. And pulmonary rehabilitation already shows that the patients are restored better. Of course, we need to use it, and the entire scope of medical rehabilitation should be done as we treat our patients. Thank you. Marina Viktorovna, thank you so much for your presentation on rehabilitation, because we get a lot of questions today on what to do after discharge from the hospital. I want to highlight the importance of respiratory gymnastics. It's a must-do component for the patients, even if the disease was not very severe. In our research, we are going to continue the talk on rehabilitation, but we cover a whole scope of events: anticoagulant, anti-inflammatory strategies, and we don't always pay enough attention to immune response. We know a lot of people who had infection, and they all have different levels of IgE and IgG. The lower comorbidity is, the lower the IgM responses. What about IgM? Valery Valerievich will be speaking about this. He will speak about the structure of identification of IgG in different age groups, because this is the immune response we are going to live with. Valerie, the floor is yours. Good afternoon, dear colleagues. I would like to present the result of our research that we conducted on the basis of Clinical Immunology Laboratory Institute after Klebasovsky, the structure of IgE in identification is SARS-CoV-2 in different age groups. Pandemics affected a lot of people globally. The number of infected people in Russia exceeds 1,200,000 people in Russia, and in many cities they introduced self-isolation. Logistics has been frozen worldwide because every country is struggling with coronavirus. Of course, to protect from infection, we should have population immunity. It can be evaluated on the level of specific G-class immunoglobulins. On the 7th of May 2020 in Moscow, they did mass testing of the citizens in Moscow for the antibodies of SARS-CoV-2 in our institute as well. In our lab, we had the blood serum of the patient from different medical organizations, such as polyclinics. From polyclinics, we had over 55,000 samples. From diagnostic medical centers, over 13,000 samples, and from emergency service, city clinical hospitals, and private medical institutions. They all send us samples. The numbers you can see on the slide. In total, we have tested 142, 183 probes for M and G class of antibodies. Testing was done by using immunochemical luminescent analysis. In the reaction box, we add the blood serum of the patient and the particles on which we have the antigens to SARS-CoV-2 virus mobilized. If in the research sample we have antibodies, then we will develop antigen-antibody complex, and then later it will be fixed by magnets in reaction chamber. The rest will be dropped out. On step 2, anti-human monoclonal antibodies are added, where we mobilize the enzyme, and later they form a complex antigen antibody. On step 3, in the chamber, we add substrate, and by using the alkaline phosphatase enzyme, we are going to generate a reaction, and later we will interpret it in specific figures and tell what they mean for clinical doctors. Having analyzed over 140,000 probes of the patients, we got the following results. Let me briefly tell you about overall antibody identification. 1/3 of the patients, 33% of the patients contacted SARS-CoV-2. IFGM, IG 6%, IgG, IgE together 11%. Then we divided all the patients into age groups using the WHO classification of ages, and we defined that the main age flow of the patients are aged 23 to 44. This is the main age group. There's another group from 45 to 60 years old. They also had a high rate of IgG and IgE. In other groups, nevertheless, we have we also had a lot of patients of this group, and this makes us draw the conclusion. The highest rate of SARS-CoV-2 was identified in the group under 60. We all know that as the age increases, we have an increasing percentage of mortality in a patient. This leads us to the main idea. Maybe there's a certain difference between acquired population immunity depending on age. After that, we decided to divide all age groups into 3 levels of antibodies. Low titration, 10 to 30 units per milliliter, medium 30 and above, and high titration 80 and above. As a result, we saw that with age, there's a reduction of both low titration and mid titration antibodies. However, with this, there's a significant increase of the IgE titers to SARS-CoV-2. The higher the age, the more the titer. Based on this, we came to the conclusion that with low and high level of titers, we see IgE, and IgE is defined in IgE of high titer primarily. What we see in the results of the current study lead us to the main thought: if there are antibodies, but people still die with high percent of probability, there are several publications on if there is a direct correlation between antibodies and death, or this is not something we can prove for sure. Besides, maybe it is caused by the fact that the younger population has a more active form of cellular immunity. At the moment, we continue studying the immune system of the patient with confirmed coronavirus infection because there are more and more questions, but we will still get the answers. In the end of my presentation, I would like to say thank you to Mikhail Andreyevich-Kankun and Alexei Bajenov for their assistance in this study. I wish you all and you and your friends, colleagues, I wish you a good health, and we will beat COVID-19 together. Valery Valerievich, thank you very much for this kind wish. I can only join it, and I agree that we have more questions. I saw elderly patients in elderly group, IgG above 300. I didn't see it in the younger groups, and there's a scary question to ask: isn't antibody virus conduit? These questions are raised indeed, but it doesn't require an answer. It requires further studies. We get a storm of questions to you, dear speakers. So, yeah, we will have a storm of questions. Without further delay, I want to give the floor to Irina Alexandrovna. She will speak about disaggregant therapy. Lots of questions there on rehabilitation of COVID-19. Hello, dear colleagues. Thank you for the organizers for the opportunity to speak at this important event. Unfortunately, there is no definitive answer about aspirin regarding the COVID-19 patients, but I want to present some food for thought that will help us in the future. So I want to start by saying that hemostasis system and immune protection today, in the understanding of the concept that has been raised in our presentations, the concept of immune thrombosis, and these two systems are correlated closely. In the last decade of this immune thrombosis concept, a new vision and the situation today as well are very often discussed. So in this concept, it becomes apparent that thrombocytes in immune response are of great importance. We don't discuss thrombocytes from the perspective of their immune activity, but initially, as we remember, thrombocytes were open and their functions were defined as an intermediary function for to stop the blood loss during traumas. A lot of time have passed, and in 90s, they said that undesirable activation of thrombocytes or the rupture of atherosclerotic clot may lead to this. And today we know that thrombocytes model the thrombocytic reaction interaction. They connect with leukocytes and they strengthen the recruiting of leukocytes and activate them. This is an important thing to understand immune thrombosis that is being discussed at the moment. Moreover, thrombocytes are expressing superficial receptors and they interact with a few pathogens. They express the so-called FC receptors, and with them they can independently recognize immune complex. This is one of the nice works published in 2014. It's called Thrombocyte Infection, New Role of Thrombocytes in Viral Infections. And the understanding of thrombocyte input in the viral infection is something we talk about. I borrowed this slide, this picture from the authors. It says that the receptors are defined. Thrombocytes and viruses can interact through many superficial receptors. For Rota, Hunter, Kawasaki viruses, for HIV, they have been defined. These receptors are known for the thrombocyte surface. Activation of thrombocytes happens not only as a response of not only it supports hemostasis, but also it modulates the host reaction and survival of the virus. During antiplatelet therapy, which is something we discussed with COVID-19 patients, we need to consider potential immune modulation effect. Whatever we see has been discussed several times. The viral there's activation of immune response, release of cytokines, and cascade and aggregation of thrombocytes that happens during the cascade of glutination. What do I want to say regarding the strategy? The therapeutic approaches to the treatment of COVID-19 are used with very high level of uncertainty of outcomes. And it was shown during our symposium that the outcomes that we expect from the therapy that we are using are not so obvious and unanimous. Nevertheless, a number of thrombotic complications occurs at very high frequency in COVID-19 patients. Today, we can follow up the patients in outpatient units. More and more of them are there. And they develop different thrombotic complications at later period. Thrombocytopenia, fibrin disintegration production, venous thromboembolism, disseminated intra lesion coagulopathy. It's not DVS, but we can observe it. Dear colleagues, I have to say that the changes that are happening, it's not only about COVID-19. The study of viral infections shows that they have been accompanied with activation, aggregation of thrombocytes, and lead to the consumption of thrombocytes and thrombocytopenia. Moreover, in vitro SARS-CoV works documented excessive expression of particular genes that have been segregated. Today, the comorbid cardiovascular complications of comorbid patients is caused by the fact that these patients are subject to higher risk of lethal outcome with COVID-19. On this slide, we see the higher troponins are, the higher the comorbidity is, the more they reflect this complicated situation and the higher the cardiovascular risks are. The group of drugs for patients with ischemic heart disease, antithrombotic therapy, hypolipidemic drugs, hypoglycemic therapy for the patients with diabetes, where we understand is the biggest problem because of the severity, but I want to show you the work, the article published by the colleagues on acetylsalicylic acid. They mentioned the possibilities. Of course, it's optional, it's for a discussion. Nevertheless, they discuss here something that we know. Yes, we know acetylsalicylic acid has antithrombotic effect. But moreover, the use of them with different types of infections led to the reduced level of in-hospital death and reduction of in-hospital MACE. All these effects of acetylsalicylic acid that are shown on this slide is something we know from our university years as we studied pharmacology. Nevertheless, today, apart from the classical effect of acetylsalicylic acid when it inhibits prostaglandin and it synthesizes and activates different enzymes, the additional mechanisms that are being discussed today, it's all very interesting because acetylsalicylic acid has some effects that impact the modulation of the core fat, and it is involved in the oxidation and phosphorylation, and it activates mitochondria. So coming back to this article on ASC with COVID-19 patients, I want to show you this very interesting slide, which shows you that when we have a change in conformation of thrombocytes, and we know that thrombocytes are very movable, they activated thrombocytes start releasing their alpha granules that contain various regulatory proteins, among other things. On one hand, they regulate coagulation. On the other hand, they begin reproducing leukocytes. Besides, they influence leukocytes, monocytes, neutrophils, and it leads to the release of a number of proteins. They ensure direct interaction between thrombocytes and leukocytes, and they strengthen the formation of germinal centers, and they lead to the IgE production. They produce cytotoxicity and ensure or not ensure the differentiation of monocytes. Moreover, it is the activation of thrombocytes that leads to the interaction and the activation of further thrombocytes, and it launches aggregation and strengthens the above described effect. That is to say, today, the inclusion of thrombocytes in the immune formation process is obvious. If we're talking about coagulopathy in COVID-19, and coagulopathy was first reported by our Chinese colleagues, I want to say that both venous thromboembolism and arterial thromboembolism are frequently encountered among the hospitalized patients with severe comorbidities. As for the lighter patients in outpatient units, for example, they also have the clot formation process. It's a micro clot formation process that may have no clinical manifestations until a certain point. Nevertheless, very often we see the signs of myocardial failure because probably there's a direct and indirect immune, let's say, caused process. Patients with arterial hypertension, diabetes, with them we see a higher lethal outcome in these patients. What are the reasons? High risks. Patients with cardiac diseases, the high risks are caused by decompensation because of the mismatch between the growing systemic reserve and impossibility to provide it. There's a high risk of complications because of the atherosclerotic clot rupture, because of virus-induced inflammation in the patients with heart failure and ischemic heart disease. Moreover, the risk of thrombotic complications as a consequence of procoagulant effect is leading to the use of both anti-disaggregant and anticoagulant therapy, and it all can cause risk reduction. Development of polyorganic failure is probably caused by pro-inflammatory cytokine response to the infection. And to confirm that acetylsalicylic acid is being discussed at the moment, I want to show you a number of articles that were written in the past, including the ones with patients with cytomegaloviral infection, patients with hepatitis C, etc. And these works show a significant effect of ASC in reducing inflammation. Moreover, today in this table, we see several studies that are conducted on different doses of ASA in the patients with COVID-19. These studies haven't been completed yet. They enroll a lot of patients. We'll see the recommended dosages and the periods these patients have, but the fact that it is necessary today to protect the patients where COVID-19 is associated with cardiovascular diseases, this is something obvious. Please take a look at the work of our Italian colleagues who presented the clinical forecast that the patients are likely to face with COVID-19. The highest lethal outcome is among the patients with COVID and ischemic heart disease and atrial fibrillation, high rate of mortality. So what can we do in this situation, especially in the patients who didn't go on hospitalization, the patients that 60% of the patients are treated in outpatient units? To what extent can we protect them from the development of negative events and consequences of COVID-19? Of course, there are lots of discussions here, but the opinion of experts is unanimous in one thing. As for ASA, the interruption of this therapy in low dosage in the patients with SARS-CoV-2, in patients with concomitant diseases, can be dangerous because of the elevated risk of cardiovascular complications. Yes, we may say that additional drugs may lead to the risks of developing gastrointestinal complications, especially when they say let's increase the ASC dosages. The main complications here, of course, happen when a patient has nausea and some other signs of hemorrhage. It's important to choose here the side effects. It's important to minimize the side effects, and we shouldn't give up using this drug. First of all, let's use the intestinally dissolved form. When it is dissolved in intestines, it doesn't damage the stomach flora. You're so professional that I don't need to speak this, but it is the form that is dissolved in intestines that helps to avoid the negative consequences for stomach that we may anticipate from a patient who takes a lot of drugs. The studies that have been conducted on this intestine-soluble form, aspirin cardio, show that it's this intestine-soluble form as compared with others that protects the duodenum and the stomach. Moreover, in comparison with other drugs such as aspirin cardium, cardiomap, Magnil, etc. These works have been published in Cardiology Journal. In terms of development of undesirable side effects, I would say aspirin cardio is of choice. I want to end my presentation by demonstrating the Russian Journal of Cardiology and a guideline on the diagnosis and treatment of vascular diseases in the context of COVID-19 pandemics. The Russian experts mention here that they recommend to continue the taking of all the recommended drugs with special attention to the therapy that stabilizes the platelets, statins, aspirins, beta blockers, etc. I'm not talking about, and here they don't mean particularly the period of COVID-19. COVID-19 will be over, but there's a lengthy period of their life and it should have a good quality. Patients of any age taking ASA in low dosages when they have cardiovascular diseases must continue taking ASA. This thing that I wanted to present shows the need and the influence on thrombocytes, and ASA is a disaggregant. As you know, we might discuss it, but I think it's very important to point it out. Thank you for your attention. Irina Alexandrovna, thank you so much for your presentation. Indeed, on the use of disaggregants, purposes, and strategy, there are lots of questions, and in fact, they have been incoming while you were presenting, and you answered many questions. Luckily, we have time for Q&A session, and in fact, at this symposium on COVID-19, it's impossible not to do it. I'd like to ask all the speakers to turn on their cameras so that we could put you on a big screen. Thank you so much again for the opportunity to participate in this symposium. I'd like to go to Q&A session and start from a huge wave of questions to you, Sergei Kinsarimовich. It's about levolumab, sarilumab, and well, let's start from these two drugs. Sarilumab, levolumab, you mentioned them in your lecture. Yes, Alexander Grigorievich, indeed, these are the drugs that from the perspective of pathogenesis look okay. These are anti-interleukin-6 drugs. With sarilumab, we know that there's no significant effect in what concerns the COVID-19 treatment. The company stopped the studies of this drug preterm. As for levolumab, we can't speak about class specificity. Sarilumab, as an anti-IL-6 drug, as I've mentioned, was making us somewhat hopeful, but it's not so definitive. Levolumab is another anti-IL-6 drug made in Russia by a Bioctat company. Despite the similar mechanism of action, we can't automatically think that this molecule is as lucky or as unlucky or the other one. Levolumab is other way of introduction, the effects, etc. We're looking forward to see the clinical study result, but so far we don't have any information about its efficacy and safety. The only thing we're sure about today is that glucocorticosteroids, including dexamethasone, work towards primary endpoint, and they reduce the lethal outcome in COVID-19. The rest requires further research. Yes, by the way, hormones are a reason for many questions on bradycardia. Well, maybe it's a consequence of massive administration of hormones, something we didn't have before. Clonkicin, a question about it. It's simple, affordable. Can we use it, and is there any experience with it? Well, you know, it's almost pretty much the same as the other things. When we start using progesterone drugs, drugs that influence the interleukin exchange or other cytokines. When we start using the drugs that influence the methodic functions, yes, they have a particular influence on immune suppression. Yes, some works dedicated to their efficacy were published, but to say that there is a well-organized study to study the safety and efficacy of these drugs in COVID-19, they are not there. And to give definitive guides or recommendations to use it, this is something we can't do at the moment, and this question requires additional research as well.
Marina
Viktorovna, a question to you. Several questions. About lung failure, we know very well that some patients respond with cytokine storm, high temperature, and we know that at this time the lungs are actively failed. But what about the patients with low temperature or normal temperature? What do we know about managing these patients? Thank you for this question. We know that, well, we know that mild clinical picture when there is no fever, but there is a change on CT imaging. But as a rule, when clinically the patient has a mild course, then the scope of lung tissue destruction is not high. So the patients, we need to rely on clinical symptoms to a large extent, and it should make us alert when we see high fever in a patient. As for mild clinical symptoms, yes, we treat this patient. But what should be mentioned here is if a patient, despite the non-expressed symptoms, has lung destruction, we need to administer anticoagulant therapy as well. Otherwise, it's just therapy for mild form. Upon guidelines. Yes, I'll join you in the answer to this question. I got a question on anticoagulants given to the patients, COVID patients in mild form and outpatient. There are no official indications for that. We may give it off-label, but we need to keep in mind that there's a certain risk. However, if you ask for my personal opinion, if the patient has risk factors, thrombotic complications, I would definitely give it, despite a very mild course of disease in this patient, although the decision should be made tailor-made. Valery Valeriyevich, you have two sets of questions. The first one is very expected. Can a person with already high titer of IgG get COVID again? Good question. As of today, there's no gradation that we chose from 80 IgE, 80 and up. In this population, we haven't encountered the patients with second COVID case. However, I met several times patients with IgE 40, 50 units per milliliter, and they in mild form, but they were infected with COVID again. The next titer was simply increasing and people felt well. But yeah, this is encountered. People who already developed immune response IgE above 80, we haven't met second case of COVID among them. So to say that there's a protective function, it is possible, yeah. This is a question many of my colleagues were worried. IgG went up to 120 and then it went down and then it rapidly soared to 160. Definitely we are dealing with a second contact with the virus, and probably the disease was either unnoticed or it was very mild. Second question, IgM. Not quite clear. There are many patients who IgM, once it is elevated, can be staying high for several months, while here IgM stays on the level 10, such as IgE for several months. What is the specifics of these patients? Why isn't it IgM going down? You know, the difficulty of M immunoglobulin coagulation is difficult because its affinity is very low as compared with IgG. And so to define it at 100% probability is somewhat difficult. Moreover, the long persistence of IgM can be caused by some cross reactions. That is to say, in our reagents that we're working with in the manual, the manufacturer already mentions that can be cross reactions with other diseases. With first COVID, for example, just a seasonal coronavirus. So these situations cannot be excluded. The maximum time of follow-up of the patients with IgM was 1.5 months. But during these 1.5 months, we studied the patient from the onset of the symptoms all the way to healing. We followed up the increase of IgM and then reduction, but this long interval of IgM detection was largely caused by the difficulties of diagnostics. Specific diagnostics of this antibody. And the third, last question to you, Valery Valeryevich. Why is it there's a particular group of patients, despite the severe course of disease, doesn't give any immune response? It's either the patient is very, very frail, weak, irrespective of the age. Is it the capacity of the immune system, incapability to develop the elevation of IgG and IgM, or is there another reason? It's a very good question. At the moment, we have 5 patients like this in our practice. We follow them up, but we're trying from all sides to study their immune system and to understand why is it that we can't catch their IgG and IgM. Maybe our test system fails to find the protective immune response of that particular patient, or there's a specific reaction of the body, and it all depends on the patient and degree of his severity. There are patients who had a positive COVID test result, but they didn't get antibodies, and there was a very mild course of disease. If they don't show antibodies, it can be explained by the fact that their cell immunity is quite well, and it works so fast that we cannot catch the threshold of antibodies when we define negative or positive. It's either slightly low or above in the gray area. If it's a severe patient, then the problems are either global immune problems, and the stage of disease is so severe that the cells cannot be produced. Thank you so much. And Marina Viktorovna and I, we recently discussed a patient like this. Despite a severe disease, he had a very small elevation of antibodies. Yes, cell test for cellular immunity is not available yet. It's only during the researches that it can be researched. However, we know that there are people who don't get sick, or if they get sick, it's a very light form without the elevation of IgE and IgM. This is another group that deserves a special attention. I want to go to the next question. Irina Alexandrovna, many questions. Patient didn't get disaggregant therapy, but he had COVID. Does he need to take anticoagulants, disaggregants 30-50 days after discharge from the hospital, or we can deal with it if we're talking about a young patient without risk factors? Dear colleagues, the questions of disaggregant anticoagulant therapy of the patients with COVID-19 are complicated. We have already mentioned that this is an individual thing. And what is an easy course of disease? I think that in any case, antiplatelet therapy should take place after the disease of the patient. What is it going to be, disaggregant or anticoagulant? It's up to the patient. In any case, If you administer anticoagulants, it will be off-label, disaggregants off-label again, if the patient has no risk factors, but we have to work in this situation. And if it's a patient with mild course of disease, light course of disease, then in outpatient, it's enough to give him disaggregant therapy. I showed you ASA impact on thrombocytes, but you know thrombocyte hemostasis is very important in the development of coagulopathy with COVID-19. Several more questions. A question to me, a patient is getting therapy with warfarin. He is hospitalized with CT, and should we move him to heparin? Yes, most probably you should move the patient to low molecular heparin with further return to the previous therapy, to their own therapy. There are several questions, and I would like all the experts to express their opinion on this. A question on hydroxychloroquine and antibacterial therapy. Let me answer first. I'll start from antibiotics. I think that the omnipresent administration of antibacterial therapy is not right. We know that there's a viral bacterial association. We know that there are criteria for the development of bacterial infection, leukocytosis, etc., some abnormal growing values of C-reactive protein, but to administer antibiotics to all patients, in my opinion, is not correct. Plus, we don't follow up the effect. For example, COVID-19, we administer macrolides, and macrolide cannot be used, but blue humoral infiltration speed is something we cannot follow up when the patient is at home. So please, you express your opinion on this popular administration. I'm not talking about resuscitation unit where destructive pneumonia develops. Antibiotics at outpatient stage. Marina Viktorovna, as a pulmonologist, you speak first, please. Thank you. It's a very important question. In fact, this off-label use of antibiotics, we know very well that it's a viral infection. And to start the coronavirus treatment with antibiotics is something we shouldn't do. And there's a particular criteria for antibiotic administration, only one. Alexander Grigorievich has mentioned it already. If the patient is in fever for more than 5 days, we might think of bacterial infection in place. Second wave of fever. He stopped having fever, the temperature went down, and then it went up again. Spirulent sputum, procalcitonin is the main marker here for us because C-reactive protein might go up as a marker of cytokine storm in this patient. As for azithromycin, which from the first days is administered to the patient, as soon as the doctor sees high fever, he administers azithromycin to the patient. Azithromycin is with hydroxychloroquine in a treatment scheme. It's in our clinical guidelines. What's the point of administering azithromycin from the very first day as an antibacterial drug? It makes no sense. As an etiotropic drug, I would say this scheme combines it with hydroxychloroquine only. And let's keep in mind the growth of resistance to macrolides. It's there, and we know about it. And of course, depending on the region, about 30% of the resistant stems of pneumococci are to macrolides, so it's not justified to administer them. Thank you so much. Sergei Kinsarimовich, what would you say from the perspective of clinical pharmacologist? I fully agree that the treatment of viral infection with antibiotics is crazy. Unfortunately, now we see that the doctors administer it here and there, in the centers where we are working, we try to withstand to this situation. But what I hear from the colleagues causes my negative emotions only, because to administer antibiotics from the first days of COVID-19 is, number one, extra drug burden, number two, it may develop side effects, and three, it's just, unjustified spendings and money waste of healthcare system, which makes the situation even worse. As for hydroxychloroquine, it's hard to comment, in fact, because the position of WHO experts was unanimous about it. As far as I understand, we often try to cling to some straws that will give us at least something in this severe situation. Thank you very much, Irina Alexandrovna. Yes, Sergei Gisarinovich, I fully agree with you. I even see some rigidity, and maybe these transformations will happen in the nearest future. Irina Alexandrovna, what do you think? Dear colleagues, my opinion coincides fully with your opinions. I want to say that antibiotics, I mean, the situation is out of control now. In the outpatient, our easy patients, I think there is almost no patient who hadn't been administered complex antibiotic therapy. Nobody is given azithromycin. They give several other drugs, antibiotics. It not only leads to antimicrobial resistance, because we will soon face this problem. After the viral infection, there always comes a growth of bacterial infection. But let's think of cardiac toxicity. This is the effect of antibacterial therapy that we are not following up now. We don't have an opportunity to follow up cardiotoxicity because there's a mass disease. We don't know how it influences the QT-rich, and I think it will be very bad for patients with cardiovascular diseases. So my urge to the doctoral community is stop administering excessively antibiotics. As for anti-malaria drugs, WHO experts said there is no evidence base there. They didn't show any effect, and anti-malaria drugs do not restrain the cytokine storm, and they don't influence the replication of virus in the organism at all. I fully agree with you. I personally saw only 2 patients who, after hydroxychloroquine, had some response and reduction of temperature, and not necessarily it was caused by hydroxychloroquine. Valery Valerievich, what do you think from the perspective of an immunologist? How justified is that? As for antibiotics, I would say we have the main market today, procalcitonin, that we will use to administer antimicrobial therapy. If this parameter is not growing, it makes no sense to administer antibiotics. So you either see high rate of procalcitonin and you administer, or you don't. Otherwise, it makes no sense, and it will lead only to something worse. The colleagues mentioned before. As for hydroxychloroquine, as far as I know, in 8 guidelines, it's still there because somewhere it got some positive feedback, but all the side effects and excessive therapeutic load is unnecessary. So if we use it only in severe situations when we have no other options at hand. Thank you very much. Thank you so much for your position. Huge thanks. While we are getting ready for a wrap-up, we have a couple of quick questions. Dear studio, please launch our video. We would like to wrap up the conference today, and we finish this symposium on COVID-19. I want to say a big thank you to the experts, and my deep gratitude to all the experts working in Red Zone today. I want to say that it is due to only joint efforts that we can cope with this situation. And we have about 2 minutes now. I'll take questions administering vitamin D, vitamin C, etc. Indeed, there is a Chinese research that showed that high doses of vitamin C intravenously may influence, but it's a small study. It has no real big evidence base. Plus, the dose of vitamin C exceeded 12 grams. It's crazy. It's excessively high. As for vitamin D, there's a series of research showing that younger people with high level of vitamin D, above 50, took the disease easier. But there is no study saying that the start of vitamin D therapy with COVID-19 in progress will lead to a better forecast, better outcome. I'll go back and say big thank you to the audience, to the experts, and I would like to conclude this symposium with a kind and hopeful video which brought together the entire medicine. Please look at the screen. All the best. See you tomorrow.
Труд в медицине, поверь, не мед. Славы в ней нету и нет банкнот. Только готовность помочь всегда. Нас вспоминают, когда беда, беда. Снова работаем, снова с заботою, снова идем к нашим больным. В красную зону держать оборону. День простоим, ночь простоим. Сутки без роздыха и нету воздуха, давят очки. И рот пересох, но ты же знаешь, зато тебе с небес улыбается Бог. Слились работа и сон в свой слились работа и сон в свой круг. Редко проводим с семьей досуг, редко проводим с семьей досуг. Но тяжелеет больной, и вот тяжелеет, и вот долг наш врачебный опять зовет. Снова работаем, снова с заботою, снова идем к нашим больным. В красную зону держать оборону. День простоим, ночь простоим. Сутки без роздыха и нету воздуха, давят очки. И рот пересох, но мы же знаем с тобой, что нам с небес улыбается Бог. Всюду со смертью идет война. В каждой победе своя цена. В наших сражениях всего трудней. Что мы теряем коллег, друзей. И снова кажется, что смерть куражится, вырвав опять кого-то из нас. Но свой исполнив, он вдруг по наклонной тихо угас.
Добрый день.
Добрый день, Григорий Павлович. Добрый день.
Я хочу
Рад
вас
приветствовать.
поблагодарить и передать вам десяток благодарностей за ваш